Well, welcome everyone to today's presentation. Feel free to engage with us throughout today's 3-hour presentation. I know it is lunchtime for some of you all, and I know things are going on, so feel free to engage with us throughout the presentation. We'll do some introductions, but I also want to emphasize you don't have to wait to the end of today's presentation to ask questions. We'll be asking you all questions to engage how you all are doing some of the work around justice, equity, diversity, and inclusion. So feel free to put those answers to the questions that we pose in the chat box, and then feel free to ask questions also of us and in the questions box, and that way we will be able to keep in line with the questions that you all have. So in the chat box, answer questions that we pose, and then in the questions box, feel free to pose questions that you all may have. So with that being said, I'll start with introductions. I'm Shantae Elbert. I am the Associate Vice President for Health and Wellbeing here at Ohio State University. And I'm also an adjunct assistant professor at Tulane for their online MPH program.
Good afternoon, everyone. I'm Dr. Sheree Watkins, and I currently serve as the Director of Wellness Counseling at American University of the Caribbean School of Medicine here in St. Martin. And I also am an assistant professor in the Behavioral Sciences Department, and happy to be here.
So we'll be tag teaming throughout today's presentation. You won't just hear from myself or all of it. You'll hear from both of us. We've split up the slides, but you'll also hear us add to each other. And if you can't tell, interesting fact, Dr. Watkins and I are identical twin sisters. And so we've been doing a lot of things together since conception. So interesting fact with your presenters today. So the objectives, we're going to talk about some health disparities around health equity among our marginalized, minoritized populations in the context in which they exist present day. We're going to also be describing the role of addressing health disparities in marginalized populations and the intersections within well-being, behavioral health, specifically mental health and substance abuse and use. And hopefully by the end, you'll be able to list at least 3 ways to address health disparities and promote health equity through advocacy and cultures of care in your work. So if I'm going to move to the next slide. So why did we say that we needed to create a sense of urgency right now? Definitely because time is of the essence. We are in a place and time and space where the stakeholders and the many stakeholders we serve are deserving of the life that they want and the life that they need, to be quite honest. And so having an awareness of where we are is an amazing opportunity to be able to provide the opportunities for our stakeholders to get to the place where they want to be. We can start today with a commitment to focus on what really matters to our stakeholders. And for many of us, it's serving our campus populations. We are often, unfortunately, also our greatest skeptics because a lot of this has been systemic and structural for quite some time. How we behave, think, act, and respond to others are born out of the many years of culminated experiences, learning, perceptions, misconceptions, and reinforcement. And so I wanted to start off by saying we need to create a sense of urgency at each of our institutions, each of our departments, each of our organizations to start to move forward and look at how we address the work that we do, because it is so important. So I wanted to start off by doing one of my favorite things is going to Pinterest and getting a slide to represent what I really want to talk about, which is we're going to start to transition into root work. And this slide talks about 2 specific quotes by Rumi. Everything you see has its roots in the world, in the unseen world. The forces change, yet the essence remains the same. The other quote talks about maybe you are searching among the branches for what only appears in the roots. So I'm gonna go to the next slide and I'm gonna pose a question to you all. And it's gonna kind of branch out and then we're gonna kind of go back into the root work. But when we think of the terms intersectionality and integrated care, does that describe your health, well-being, and academic support departments at your institutions of higher education? Yes, no, maybe, somewhat. Are you all looking at how you support students' health, well-being, and academic support from an integrated care model through an intersectional lens? Yes, no, maybe, somewhat. Curious to see what you all say in the chat box. And if you're not, it's okay to say no. We hope to. Okay, we're gonna go to the next slide. Okay, Dr. Watkins.
So
So go ahead.
when we think of student centered care, there are a couple of things that we want to discuss in regards to student centered care. We want to provide care that is respectful and responsive to individual preferences, needs, and values. And just remember that as we're trying to provide this care, have a true understanding in that wellness is a journey of healing and transformation, enabling students to once again live meaningful lives and really define what that meaning may be for each one of them independently. And most importantly, as they're defining this meaningful life in this community, which is typically grounded on campus and also externally that surrounds campus, really having choice in how they define that while still striving academically to achieve their full potential. So it's important to convey a sense of hope that is achievable for all. And I'll let Dr. Watkins talk about, Dr. Elbert talk about the 6 dimensions of student-centered care.
So over time, we've been really trying to look at my current and previous institutions, how we try to look at student-centered care. And these are some things that are definitely things that I have centered in my approach and practice over the years. But the first one I want to talk about is respect for the students' values, preferences, and express needs. Because again, we oftentimes say that we welcome the diversity of our students and their experiences and we value their beliefs, but we don't often showcase that we respect that in how we engage in the work that we do. We want to also emphasize that we have a coordination of integration of care on and off campus. A lot of times, campuses cannot offer all of the extraordinary services that can be beneficial to our students. And so, how do we do that from a place of supporting students from a holistic model? We want to make sure that we coordinate the services. And so, I'm not a fan of saying campuses have to have every type of health and wellness service, but I am a fan of saying we have to be able to coordinate those services and referral processes from on campus to off campus to support our students. Information, communication, and education have to be centered in our approaches. That way, the students get to be a huge centered part of their own personal health and well-being. They have access to the information, they get to be part of the communication, and they have the ability to educate themselves and their support circles and their peers. And so those are central to making sure that the stakeholders are centered in our care approach. Physical comfort in setting, place, and space, emotional support, and that could be from those who work on campus. I always emphasize that the emotional and physical support doesn't always have to come from those of us who are within the clinical and prevention settings. It can be from the other staff on our campuses. Me and Dr. Watkins had great relationships with many people on campus, but some of the people who made the biggest impact was in our dining facility and those who worked in housing as the housekeepers. They checked on us, they loved on us, and they cared about us. They physically made sure we were okay consistently. They emotionally checked on us. And so I want to emphasize that that physical and emotional support can look very, very different. And last but not least, involvement of family, friends, and support persons in that care. Obviously, some of this may require waivers to be signed and things like that, but it can be done, and making sure that they know that their family, their friends, their support persons can be involved in their treatment, their care, their well-being, as long as the appropriate documentation is on board. So looking at some questions, I want to ask you all, what spaces do you all have on your university that nourishes and allows students to be and breathe? If you can share in the question box or the chat box, what are you all doing to provide spaces that allow students to just be and breathe, that especially are not organized as a very specific, like student organizations tend to be examples of that, but sometimes it's through programming. I'm not talking about specific programming, but outside of that, are there specific spaces that you all have that allow your students to be nourished and allow them to just be and breathe as whole persons on your campuses? And while some of you all are thinking about what you all are doing, Dr. Watkins, do you want to share what you all are doing on your campus?
Sure. So some different ways that we are currently creating spaces for our students to be and breathe is that we're really trying to restructure two different components. Number one, our new students, their income every semester. So here at AUC, we have 3 semesters per year, January, May, and also August. And so we're really trying to orient and build community with those students through an orientation process that's interactive, that really focuses on the whole student. So something simple is taking them grocery shopping, understanding the dollar and also the other types of currency that's used here in St. Martin, to understand the differences in prices for food, how to budget based off of your financial status and also the needs that you may have. And so we really try to create these engagement moments with students, not just with going over the technicalities of how to sign up for your classes, where are your classes, how where's your dorm, and how to look for apartments off campus. But we also look for ways to engage them and making sure we look at them as the whole person, which is inclusive of linking them to community religious institutions, also having 2 or 3 of those institutions on campus. Secondarily, we have close to 21 student organizations, and many of them are related to race and culture, on top of interest as far as in the medical field. And so we're trying to be as creative as we possibly can to create these different types of spaces, from onset until once again they matriculate and get into their clinical sciences rotations.
Got it. And thank you for the example given in here that one of you all shared there was only a couple of spaces specifically for multicultural spaces for students to hang out, dining, hangout spaces, but you think there should be more, that it's a home environment for students with couches and comfort. Absolutely. The thing we talk about is that we bring students to our campuses, um, and we ask them to make this their new home, but we don't give them a chance to make it a home. We ask them to acclimate to our campuses versus how can they also bring some of their ideas. I know a lot of times we talk to certain students and they talk about prayer spaces, meditation spaces. Some campuses have involved by having sleeping areas across their campuses, especially for those who have a lot of commuter students, but even for those who have a lot of high functioning students where sleep has been an issue and concern. But so you want to look at how you provide spaces for nourishment. To look at, for us, it can be within those dimensions of well-being. It doesn't always have to be an office. Some campuses in Canada who have embraced the Okanagan Charter have done outdoor social spaces. I know Wake Forest University has some outdoor spaces. Georgia Tech has done some outdoor stuff. And so I really want to emphasize that nourishment can be through a variety of lenses, and don't always look at it just from a physical structure, as in, do they have a department to go to? Look in a very innovative way. And so one thing to keep in some of these questions that we're asking you, these are things that you can ask your teams. And so they'll, while we have these up here and you will get the access obviously to this recording, these are things that you all can take back to your team. So if even if you don't have answers to some of these questions, these are things you can take back to your unit, to your divisions, to your departments to start doing some of this deeper dives and how to look at justice, equity, diversity, and inclusion. And so with root work, we know is seen as addressing root causes or drivers of unhealed wounds and unhealthy behaviors, thoughts, and actions. It's based off this specific definition. And so how do you engage your minority, minoritized, marginalized populations at that intersection of wellness and well-being and academic success? How can your department create services and programming that caters to them? So we're going to look at this number 2 question that we're asking you to start thinking about, and we're going to dive deeper in the next slide on how to start addressing root work. So I want to emphasize root work is definitely something that I am used to hearing. My sister and I, because we're from the South, and this is definitely something that we've heard many of our lives, because it's one of those things that culturally we've always heard about getting to the root of the problem. But it also pays homage to African American and Indigenous populations in medicine, and how they approach healing and holistic work. More broadly, the name honors the wisdom of the old, the ways of Indigenous medicine, which is at the heart of the work itself. I also want to emphasize, when you look at it from a more holistic perspective, the root chakra, for those who do a lot of healing work and chakra work, is responsible for your safety and your security. And when you look at the root chakra, it's comprised of whatever you feel is your grounding instability. And I'm using the word grounding for a specific purpose, and we're going to come back to that in a quick second. This includes our basic needs around food, water, shelter, safety, as well as our emotional needs, such as also being able to let things go that are fear bound for us. And when these things can and are met, we can be grounded and feel safe. So the goal for a lot of the work around root work is justice work, and it's nourishing. It is allows us to be in spaces to be and to breathe. That is the goal of root work. And then when you have that intersection where there is a world where BIPOC, Black, Indigenous, people of color, who do this work, educators, clinicians, preventionists, artists, culture workers, and others, they can also, in time, at the same time, hold space and thrive. Above all, when you look at root work, this is a space and place where we can reclaim joy. Often when we start getting to the next couple of slides and talk about trauma, this is something that is impacted. And so to be able to reclaim joy is a huge part of root work. And it allows you to center a space and understands the call to create healing, justice, and more importantly, where our ancestors met, where our ancestors meet. And so when you're working with populations that have dealt with historical and systemic trauma, and we're going to talk about that in some upcoming slides, looking at it from a very root-centric, root work approach is definitely necessary. But I'm going to go to the next slide and give you an example of um, how I've been approaching it present day in COVID. So I don't know any campus that didn't have this happen. You did COVID surveys and assessments, and you had increased anxiety and depression outcomes for your students. If you didn't, I would welcome you to put a note in here to let me know, because what I've seen across the country is in higher ed articles, the Chronicle, all the articles that's been coming out the past 15, 18 months has showed an increase in anxiety, depression, and other mental health concerns and disorders with our population. Is it shocking for anyone who does this work? Not at all. But one of the things I've been asking is, okay, we've seen this, so not at all. So we've seen this happening, but one of the things that makes it even more interesting is I've asked those who've done these surveys, did you ask a follow-up question to your survey? Did you get to the root? Because I said, and I said this in some meetings. I said, did you ask the question about within the past 30 days, have you experienced these symptoms? And you described anxiety and depression, but did you ask what the causation was? Or did they present to your clinics and say, these are the symptoms, and you diagnose them with anxiety and depression? But if they didn't present in the clinic, but they just took a survey, did you ask them what was the root cause analysis of the exacerbated presentation of anxiety and depression? Because if you ask any APITA students, any international students, any Black or Brown students, the past 18 months, there have been two major things going on: COVID and the final the final visualization that we have a structural and systemic problem around racism in our country. And here we are. Those things have coincided. So it hasn't been one pandemic. It has been a pandemic, and they call it the reckoning happening at the same time. And so, but when you ask students who are from these populations, and I also want to include our low SES students, Pell Grant eligible, poor students who are on the margins already, are they feeling exacerbated anxiety and depression? It is no shock that they had increased anxiety and depression, but we didn't also ask them why. Was there anything that exacerbated it? And so we got all these survey results, all these articles came out, and nobody digged deeper. So nobody can actually say it was just COVID, but that's what everybody is saying. It was just COVID. And so root work in the work that we do and switching our lens on how we approach this work goes back to the previous slide that says it is the place where we meet to talk about the justice of the work, to start a place of healing. But you can't heal unless you actually know the root cause of the problem. And from the root cause, we systemically and structurally start to address it. So you don't have somebody with a broken arm and give them a Band-Aid. You take an X-ray, you determine if a cast is necessary, or do they need surgery and need to get something serious done and have surgery and have some screws and things put in. You just don't approach it from a place of, oh, that's just going to be easy. But that's how we've approached it just from COVID. But for those of us who've done this work longer, that's how we have approached it with a lot of work we've done in college health and wellness. And so now you get the sense of where we're going today. Welcome. I wanted to start us off there because now we're going to start transitioning to the foundation of trauma. Because now we can start diving a little bit deeper into where we are. We'll do this. We'll have a short, both of us have small munchkins. We'll take a small, short potty break. We'll dive back in and finish the rest of the presentation. But now you can see where we are. And thank you, Tatiana. I appreciate all the love in the question spots. But I see that you said even what exactly about racism and COVID that can be addressed immediately on campus. It's the hard part about it has been easier to some degree to address COVID because there have been resources provided. But to address racism requires the support from senior leadership and from trustees and cabinet. And there are campuses who have not been given the autonomy to start having conversations about racism. And so I won't say that some campuses haven't had it. I'm saying that some campuses haven't been granted the autonomy and the social capital to start having that conversation in a very transparent way without potentially having some repercussions. And so I wanted to emphasize that because that has been systemically what has held us back in looking at things a little bit differently. So I'm going to turn it over and let Dr. Watkins take over and talk a little bit about trauma.
Thank you, Dr. Elbert. So as we're talking about getting to the root of things, we're going to start off with this question for you to think about, and you also can provide some answers if you have some. What are some common behavioral and psychological responses to historical trauma? For short, we call this the historical trauma response. But what, based off of your best guess, are some common behavioral and psychological responses to historical trauma? So let's talk about what exactly is historical trauma. Historical trauma, also known as intergenerational or multi-generational trauma, is caused by events that target a group of people. And when we look at that group of people, it is related to major events that either that typically oppress a particular group of people because of their status. And so the examples that we have here that we will mention will be slavery, the Holocaust, forced migration for indigenous people, and the violent colonization also of indigenous people. But what we know is that historical trauma is cumulative, multiple layers. And once again, it reverberates across multiple generations. So even though when we're looking at indigenous populations, Asians, Hispanic, and also African Americans, though many, when we're talking about now, many of those generations are no longer living who experienced slavery or who experienced Jim Crow or once again migration or once again different types of oppression. It spans even to the current generations that you see on your campuses now. And descendants who have not directly experienced the traumatic event can exhibit the same signs and symptoms of trauma. And so what we know is that historical unresolved grief is one of the main accompaniments of this type of trauma. There is so much type of grief, and some of the main types that we talk about is grieving from the loss. And when we talk about the loss is like um, this big open space as exactly what we're grieving from. We're grieving from the loss of possibility, the loss of life, the loss of quality of life, sometimes the loss of health. And so there's multiple different things when it comes to unresolved grief. And one of the most profound one is the grief of, but I got to make it. I made it out. And that's a major burden for many current people from these different types of minority and marginalized populations. So I want to switch over and look at the conceptual model of historical trauma. Can we skip and we'll come back to this one, Dr. Elbert? Okay. So when we're looking at the conceptual model, we can look at it starting from the very top and looking at the mass trauma experience, which is the initial group that was exposed to the trauma. We see the dominant group, and then we see the subjugation of the population. So the dominant group oppresses the subjugated population. Some of the different types of examples we see is segregation and displacement. We see physical and psychological violence. We also see economic destruction. And then lastly, another example is that we see cultural disposition. We typically hear about this versus, acculturation versus assimilation. Do we assimilate to the larger, more dominant group? Or do we once again we acculturate and we're able to understand and immerse ourselves in the dominant group while still maintaining and retaining our cultural identity? But what we see as we move down this model is that the first generation or the primary generations of that initial subjugated population now also exhibits the different types of trauma response. And once again, not going over all of them specifically, but what we look at the trauma response is that there are resilience and protective factors that we look at up under each type of response. So up under physical response, we look at nutritional stress. We look at, once again, biochemical abnormalities. We look at, once again, maladaptation when it comes to how the body is physically changing from the inside to the outside in relation to the historical trauma. Then we also look at the social response. We look at increased suicide rates, increased mental health diagnosis, increased substance use, unemployment, and also child maltreatment, and also poverty are some of the common ones that fall under the social response of historical trauma. And then lastly, we look at the psychological response. Post-traumatic stress disorder, depression, panic and anxiety disorders, and once again can result in shame, social isolation, grief, and withdrawal as a part of those diagnoses and also that response. So when we're looking at this model, we are watching this flow of how it went from the subjugated population to the first generation. And now as we move down to the secondary and subsequent generations, so that's everything that came second and after, we see what we call this intergenerational transmission, meaning that from present to past, past to present, we still see influences of this historical trauma on health disparities. Health disparities such as, once again, physical health. Once again, when we're looking at chronic disease, when we're looking at suicidal rates, when we're looking at, once again, poverty and socioeconomic status, what we know is that the modes of intergenerational transmission still once again covers physiological, genetic, environmental, psychosocial, social and economic and political systems, and also legal and social discrimination. So everything that has came after the second generation has some type of impact, direct and also indirect, in each one of those different categories. They're either directly affected, so it may happen directly to them, or they're indirectly affected or impacted because it's happening in their either their immediate family, their immediate community, or once again within the entire population. So let's go back to the previous slide and talk about some of the different examples of structural factors of racism that represent historical trauma. We have the post-traumatic slave syndrome, which is the condition that exists as consequences of centuries of chattel slavery, followed by institutionalized racism and oppression. We have the American chattel slavery that was between 1619 and 1864, with the importation of Africans, once again coming from various different types of countries. We have the Jim Crow era, which was between 1865 and 1965, where we saw once again the continued oppression of Black bodies, and once again when it comes to equality, and also now the more infamous term equity. We also saw the 13th Amendment come into fruition that abolished slavery, but either slavery nor involuntary servitude once again was actually subjugated to any type of punishment as a crime. It was still continuing, it was still being done. And we saw this through, once again, the laws of sharecropping, where they never quite was able to make it out because they were still paying on this land with the work that they was actually providing for it. And then we have convict leasing, the emergence of the Ku Klux Klan, and then also centuries and era of lynchings that crossed the U.S. and also which included castration. When we look at some facts and figures, we know that there's about 4,700 southern states that actually had lynchings that was actually documented that we can account for. And about 219 in the northern states. So not as many as in the southern states, but it still was occurring up north also. And then from 1968 to 75, and I wouldn't necessarily agree with the definitive end of 75, we had the emergence of the ghetto and welfare. We still have it. So that's why I'm saying it's not a hard stop at the end of 1975.
And I want to emphasize, if I'm not making a mistake, Hiyam mentions that to recognize our Middle Eastern, North African populations. Absolutely. But I want to emphasize, we're going to talk about our experiences of working with our students here on campus. We are seeing an emergence of more work on our international students who are here on our campuses. And there's so much more research out there, but we still don't have enough research on our native students of color. And so absolutely, we need to have more research done. But even some of the research coming out now on our APITA students and how I was on a conference call and the desire to look at demographic information and disaggregate APITA categories was a topic across the country. And even within that population, there is different perspectives based off socioeconomic status, but also color of skin. So they have some colorism even within that population. And so we have still so much to learn for those who are part of our populations, our citizens here. But we're going to mostly focus on those who are native to the U.S. and on our campuses, because that has been a huge gap, and we haven't even addressed that. And so we still have a lot more work to do with our international students, and we have more work to do with our students who are also parents, guardians, support persons, and those who are differently able. So we have so much work to do in different identities and those who have multiple identities that cross over. But I want to emphasize this is from definitely from our lenses of the work we've done for the past 15, 16 years in higher education, and in Dr. Watkins working in outside of higher education as a clinician in traditional healthcare systems. So I just want to emphasize that our perspective of what we're bringing to today's conversation.
And it's not included because we didn't want to dig too deeper into the historical trauma pieces, but just as a reminder, historical trauma impacts multiple races and cultures. So even though we've talked about indigenous populations, Asian immigrants, and also and Black, it's not an all-inclusive one. So once again, there's so much more as was mentioned in the comments. But some of the most common features from historical trauma response are once again very interesting, because these are some of the most common issues that we're also seeing on our college campus among marginalized populations. And when I say marginalized, I mean marginalized populations. When we look at the data, when it comes to mental health disorders, suicidal ideation, and substance use, our marginalized populations, everything from looking at race and also looking at sexuality as far as LGBTQIA, says that these populations are typically more predisposed 2 times, 3 times, 4 times, 5 times more likely to exhibit and also be diagnosed with these different types of features compared to those of the dominant race here in the US. And so once again, when we're going to the root of it, now we have to begin to understand that some of it may be based off of current issues, but that's not where it starts. Because how me making it into college and coming out of the projects, once again, how did my family get into the projects? What was the setup like for that person's parents and their parents? And once again, and looking at their the abilities and also non-abilities when it comes to financial wellness and status. And so when we're looking at these different trauma responses and futures, again, it's systemic and systematic. We're seeing it over and over again. And so when we're looking at these futures, one thing that I, as being a clinician, I try to make sure I emphasize to the counselors who service our students, and also when I'm training faculty and staff, that it's not just depression. Depression looks differently from everyone, but once again, we have to get to the root. What is the cause of the depression? And once again, is it layered? And once again, in order to deal with it, it's not just about automatically shooting them to counseling, which is also great, shooting them to student health for medication. It's really about creating a system of how can we really address all of the causes, or the main cause of this person's symptom. And what's been interesting, and so in my previous role, so I've been here at AUC, which is the acronym for the university that I work for almost 2 years. But prior to that, I have worked in multidisciplinary teams in working with marginalized populations. So for about 5 or 6 years, I worked with those living with HIV and AIDS, particularly working with minority populations. And then I transitioned another 5 to 6 years in working with populations of people living with lupus, sickle cell disease, and also hemophilia. And what I've learned is that when we're looking at it from the root lens of historical trauma, we now have to have this understanding of what we know as epigenetics. Epigenetic studies provide a unique opportunity to categorize the long-term impact of stressors, including historical trauma, on the function of our genes. And our genes make up our organs, make up our organ systems. Once again, we have to make the connection. And the modification of gene function through epigenetic modifications can greatly impact the health of the individual and may underlie some of the health disparities that we observe in populations, and in this particular example, Native Americans. And so as we go to the next slide and we further talk about epigenetics, we have really been trying to change our way of working with chronic disorders by looking at it from an epigenetics lens, especially when it comes to sickle cell disease, lupus, and cardiovascular disease. Because we know there's some genetic changes that has occurred when we're talking about when working with these populations. And what we are attempting to do is that we're trying to look at the lifestyle factors such as diet, stress, and exercise, and how can these actually change the way your genes are expressed. So really creating different types of diets and exercise regimens and stress modifications that are targeted towards certain populations. Because what we know is that it adds up to the effect things like health risk, disease, and also overall well-being. So it's much more than just, once again, gene modification. Because the last part that we have seen is, once again, looking at those genes modifications and looking at how and what we prescribe for certain populations when it comes to medication. Doing deeper dives into a person's DNA and genetic makeup to determine if I'm trying to treat certain diseases and cancer, can we target it based off of what we know through research? And so we are continuing to evolve so we can now take this very popular term of person-centered, but really also make it more gene-centered.
And so looking at the images that we see, we just talked about the Dana, as we call it, the DNA, but now we want to talk about how we are being impacted as far as the impact of racial trauma, and the images have meaning. And so one of the things we've been talking a lot about with students, and being mindful of what they consume visually, is the impact of those images. And so not just for the students, but one of the things I've been talking about with my staff, and how to disconnect is the images that we take in, as far as my team, the health and well-being team here. And so how do we use all of our senses for those who have all of our senses, and for those who have some senses or may not have visual impairment? How do we look at the impact of what we take in visually and in the work that we do? A lot of us do a lot of health communication plans, a lot of social norming that have flyers and things like that. A lot of us have TV screens that have messaging up. And so when we look at how we approach this work, and how we look at it from a very sensitive and inclusive lens, just want to be very mindful of the images that we use and how it can impact some of our minoritized, marginalized populations. And this is just an example on what has been triggering for many of our students and many of our BIPOC preventionists, clinicians, and higher education, student affairs experts, and faculty, of when we see certain images and how it can be triggering, and make us go to a place that makes us realize of where we're still at and where we have not been able to transcend. And so when we have a look at the overview of some trauma characteristics, especially with the pandemics that we have been exposed to, we looked at it within our healthcare systems. And one of the things that have been really overlooked in this process is the effect of healthcare workers. And so all of the conversations that have been centered around healthcare workers have been around traditional healthcare. But one of the things I have been trying to emphasize is looking at the healthcare workers on our campuses too. Our counselors, our student health center staff are all burnt out. Many of them have never left campus, and maybe some of the counseling staff have. And then going beyond the healthcare workers, going to our frontline staff, such as our housekeepers and some of our staff who live on within student life or student affairs within housing, who stayed on campus this entire time and have been potentially exposed to COVID throughout this entire pandemic that's still going on. And we know that some of our PETA healthcare workers and students and employees have been endured some serious trauma around racial discrimination. There have been those who are practicing patients being refusing to be seen by them, accused of causing the pandemic, some even being physically assaulted. And then even within higher education and healthcare, workers have been no exception of actually experiencing some of the racial biases. And notwithstanding, we haven't addressed the long-term effects of this trauma that they have experienced. And so we went from micro to macroaggressions to blatant hate crimes, and we haven't found a way to start to address it. And we've asked many of our staff to step up and continue to do amazing work, but we haven't found a way to address some of the things that they're trying to help our students, but we haven't found a way to help them at the same time. And so I wanted to emphasize that because the trauma that we're trying to assist our students with is the same trauma that many of you all and many of your team members and colleagues are also trying to deal with. And so looking at it, I know Dr. Watkins already talked about PTSD when we looked at the chart when it came to the historical looking at trauma, but I wanted to emphasize when we look at people who've experienced trauma, they also have mirrored symptomology of PTSD with the re-experiencing, the avoidance and arousal. And so one of the self-care wheels that we can use around that is right here on the screen, and you all can get it from olgaphoenix.com, or you can find a different one. But self-care for many of our BIPOC, minoritized, low-income students is active radicalism right now, because it is a privilege to be able to do self-care. And I think a lot of times we don't think about that when we talk about trauma, when we talk about working with these populations. We do a lot of conversations about resiliency. We do a lot of conversations about self-care without thinking about the implicit impact of when we say those things, going back to imaging, but also the words that we use that can be very triggering. Why do these populations, why do these students even have to be resilient in the first place? Why do these students have to find ways to be so proactive in their self-care when there are things that are systemically and structurally enforcing this necessity? And so I wanted to showcase this because a lot of times, as Dr. Watkins talked about, it can be very, very hard for many of our students to learn how to engage in self-care when they're actively still re-experiencing trauma, specifically racial trauma or violence, present day. Some other things around trauma, we already talked about it in the longitudinal sense as far as research, but present day, we still seeing some of the common emotional responses that we saw through the research as far as fear, anxiety, shock, belief, anger, shame. So going back to my first question when we got to the second slide around root work is, did we ask the subsequent questions around causality when we asked about anxiety and depression, knowing that here we are, many of our students have experienced lots of forms of anxiety and depression, or been having traumatic experiences. Some of the common physical responses: trouble sleeping, nightmares, fatigue, exhaustion, very clingish, or the opposite, isolation, hypervigilance, elevated startle reflex. And then within cognitive responses, we've seen a lot of distractibility. I've seen a lot more students ask for evaluations for ADD. We've always had an influx of college age students asking for assessment, but even more so now than lately. We've seen declining schoolwork performance, and without talking to faculty and staff, it could seem like they're not engaged, they're not really wanting to be here as students. And so it looks very different if we don't have these conversations with faculty or those within student affairs, student life, who are also faculty and teaching some of these courses. It can seem like our students are not engaged or invested in their academic careers. And then when we look at the impact of racial trauma and the harmful impact it can have, we know that it has and it will continue to create a hostile and invalidating work and campus climate. That has been consistently proven over campus climate surveys. We've done work environment surveys. I mean, it is already present in as much research as you can literally Google. We also know that they've started to at least start to centralize the impact of racism and a lot of other isms and the impact on physical health. And we're starting to see more research start to come out that has been centered by the American Public Health Association and other national organizations about the impact of racism and other isms on physical health and well-being. And then we all have already seen within the workplace, it lowers productivity, problem solving abilities, and we see lower retention rates, and then we see that revolving door of employees. But I want to emphasize this: we see it with students too. If they don't feel safe, they don't feel welcome, they don't have a sense of belonging, you'll see the same type of revolving door of students not staying and matriculating from semester to semester, quarter to quarter. Some cultural factors that I want to emphasize that make sure that you and your teams are thinking about when it comes to there are disasters that influence reactions and coping skills. Oftentimes we don't think about these things, but these are some things I want you all to consider. National origin, customs, and traditions are valuable. I remember sitting in a training, and somebody said, well, I don't give extensions on exams without what was it? If there was a bereavement or death in the family, without having an actual sign of what is it? The program that showed that there was actual. Well, that's not normal for everybody to have a program for a funeral or a wake or a service, and so being mindful of the customs and traditions are not the customs and traditions of everyone. Um, Gender, religious, political beliefs all impact how we deal with stressors and disasters, and our what coping skills have and have not been developed. And I want to emphasize that if we were teaching this to students, my sister would probably have her famous piano graphic up on the screen and talk about what has to be taught and what is natural and innate. And coping skills and emotions. Some emotions are natural, but the coping skills necessary to deal with struggles and tough situations have to be taught. And so when we say, things such as having coping skills is common sense, is not. These things have to be built into the framework of how we do what we do. And then last but not least, for my slide, and we'll transition, when you're experiencing trauma, what can you do? From organizationally, for those who get a chance to lead groups of people or departments, you want to encourage resilience, but not from a place of pull yourself up from the bootstraps, but emphasizing the amazing work they've done to get to where they are, using more of a coaching mindset, and not saying that there's something more you have to do. Resiliency has been necessary for many populations for a variety of reasons. And so you want to start from a place of strength and not deficit. Team grounding, and that starts with actually knowing your team. And it's really easy to do that. Resiliency, encouraging resilience once you've had a grounded team. Communication, peer support, and having a mindfulness practice built into the framework of the workplace culture. Within your individual selves, self-reflection, enhanced self-compassion, focusing on the here and now, mindfulness, grounding, finding a way, when possible, to separate work from home. Hard for many of us lately, but necessary, and more importantly, listening to our bodies. And I see a comment about the documentation of obituaries, and it is something I believe ethically we should not be doing. If we don't have to, outside of FMLA and other serious things for our employment, turn in that type of verification, why are we creating that same practice for our students? I just want to emphasize that.
So now we're going to be talk about racial and ethnic disparities when it comes to mental health, substance use disorders, and healthcare on collegiate campuses. And just because we're focusing on the collegiate campus doesn't mean that there's not a parallelism when it comes to community-based organizations also. So to kind of get us started and ground us, we want to start off with understanding the 4 dimensions of racism, because you've heard us use these terms, but let's actually make sure we all understand what these terms mean. So we have systemic racism, which is a system-wide racial inequality from the collective policies and practices of social institutions. And the institutions that we most commonly refer to is law and legal, education, and also mass media. And within systemic racism, we have structural racism, which is racial bias among institutions and across society. It's also cumulative and compounding when it looks at the societal factors, including the history, culture, ideology, and interactions of institutions and policies. The next type of racism is institutional racism, which occurs within institutions and systems of power. Unfair policies, discriminatory practices of institutions, everything from schools to workplaces, healthcare, that routinely produce racially inequitable outcomes for people of color and advantages for white people. The next type of racism is what we call individual or interpersonal racism. It is racism by the individual, such as one's prejudice, biases, and one example listed here is xenophobia. But it is a prejudgment or a bias or discrimination by an individual based on race that affects their public interactions with others. And then the last type of dimension of racism is systematic. Systematic says is that racism that is engaged in a methodical and also according to a plan. And can be carried out by various parts of the society, but by individuals or even institutions. And so when we're talking about institutions, we want to be able to look at the institutions here. It's going to be healthcare, it's going to be our treatment facilities, and also, once again, our universities. So in looking at the statistics, African American and Latino students reported half the rates of being diagnosed or treated for anxiety, depression, and self-harm when compared to white students, but reported feeling less safe and more isolated and being more likely to keep their feelings to themselves and not seek out help. Secondly, this lower rate of being diagnosed, and once again, also having a decreased number of in relation to treatment, also is related back to once again how these different types of organizations and institutions are looking at racism, and also through that lens, maybe looking at biases related to anxiety, depression, and mental health disorders. So what are the reasons why minority students, typically in the past studies, for an example, is not entering into our treatment spaces? One, stigma. I need to come off and be perceived as being strong, that I got this, that once again, I'm not crazy, are some common responses that we hear. And then the lack of access to care. Again, and sometimes in communities, the closest mental health facility, the closest substance use treatment facility is not in our backyard. We may have to take buses, and 2 buses are in a car. Once again, take an Uber to get to treatment. And so we know that being on college campuses, that most have student health centers, but once again, there's still a stigma, and once again, they're still less likely to enter into services. And the difficult part is that by the time many marginalized or minority populations and students enter into healthcare services of any type, they are typically more severe and profound compared to their counterparts. Mistrust and fear, which is definitely carried throughout generations and generations, because there has been a precedent set. Stolen genetics, once again, getting treatment, false treatment, when it comes to certain types of diseases and being given certain types of diseases. Studies based off of in Mexico, once again, giving them chlamydia and gonorrhea. And then, of course, we have the different types of studies as far as the syphilis, as far as Tuskegee, when it comes to, once again, Black men. So again, many people and populations have their reasons to fear and mistrust the health community. Striking disparities in mental health care for people of color, because once again, they're less likely to receive services. You'd be surprised how many times I've heard people was told to, just suck it up, or it's not that bad. Poor quality of care. There have been multiple studies in which you can have two of the same types of diagnoses. They will go in and have the same type of symptoms, and once again, they even may have the same type of jobs, but will receive different levels of treatment when it comes to it. There were some studies that was done to show a person's likelihood when breaking a bone in their body. What was the likelihood of them once again getting pain medications while they was in the ER, waiting to get X-rayed, waiting to get a cast, or waiting to get once again a sling? And what they saw in that studies, which was multiple ones, is that minority clients and patients were less likely to get any type of pain treatment to at least make them comfortable when they were doing different types of breaks. So once again, it's very pervasive. And even when it comes to mental health, they're less likely to be prescribed something, or sometimes they're misdiagnosed, which we'll talk more about. And then immigrant populations. Once again, looking at Asian American and Hispanics, for example, with limited English proficiency, we have to look at, once again, the health literacy. Do they know how to engage and matriculate through many of our systems that we have set up? And then once again, the cultural perception of mental illness affects the likelihood of them coming into care, staying and being retained into care. Also, once again, feelings of shame and weakness. And once again, help seeking at crisis stage rather than earlier, as you heard me mention before. So as we shift, we're now going to talk about, the cultural diversity in college health and wellness. So what are our lenses that we typically look at when we're talking about health and wellness, or sometimes called well-being, on our college campuses? Who do we target? Who do we overlook? Where are we now when it comes to creating integrated services and care? Where could it be? And how do we make people of different ethnicities, gender, and age, and other different types of demographic characteristics comfortable in our presentations, in our presence, okay? And so these are some of the questions that you can ask yourself when trying to gauge, are your services, once again, culturally diverse when it comes to health and well-being services? And then what lens are we typically treating our students with? Because what we know is that not everyone needs to be treated up under the lens of the medical model. Many, once again, would not seek that model, would not stay in that model. And so we have to be creative and also culturally appropriate when working with marginalized populations. So what are some influences on when it comes to minority cultures on mental illness and mental health? We can see this influenced by, once again, how they communicate. So one of the examples that I often share when I'm doing these types of presentations is in working with minority women over the past 12 years. I have seen how they communicate their issues, their needs, their symptoms, and even the manifestation of the symptoms to be different. One of the most common things I hear when it comes to minority women who are middle class working is, I don't feel like I'm doing enough, or I feel like I need to be doing more, or I need to be able to help so and so and still juggle this, and how do I juggle it all? And what I've learned is that sometimes it's not just about stress management or setting boundaries. Sometimes them sharing that language is actually them exhibiting, more times than likely, symptoms of depression. But that's their way of being able to describe it instead of saying that I'm depressed. Saying I'm overwhelmed is more acceptable than saying that I'm depressed. And so we also have to look at the cultural influences of coping skills. What were we taught in our homes? Did we see stress management, and did we see, once again, in ways in which we handled difficult situations, which is inclusive of mental health and illnesses? And then what is the range of family and community support and the willingness to seek treatment? Have I sought treatment before? What was those experiences like? Because it's very important to understand that the willingness is also based off of a couple of different things. Is it accessible? Once again, is it within my financial means? Are there people, once again, within these service entities that I can feel comfortable with talking with or look like me? So as we're looking at and asking ourselves, so we know that there's a disparity when it comes to the treatment of mental health and substance use disorders across different multi-ethnic ethnic groups. So when we're looking at this continuum, we first address what are some of the barriers. Some of the most common barriers that we see are related to personal and family, structural, and also financial. So some examples of personal and family is cultural beliefs, language and literacy, health behavior, education, and income. Structural, excuse me, as you just heard me mention, it may be based off of transportation, availability, appointment variability. And then financial, is it covered by insurance? Is there reimbursement? And what is the public support associated with this type of treatment? And then as we flow down this continuum, we look at the mediator of the use of services. once again, people with a primary care doctor are more likely to seek and enter into mental health or substance use care because they have that connection with the primary care doctor. But typically, what we see is that for those who are sometimes seen based off mental health or substance use disorders, they're typically, once again, they more time than likely for adults don't have a primary care physician to really tackle that preventative care and also underlying treatment. And procedures, do they have preventative treatment? Do they have the education, once again, to receive, to enter into treatment facilities to get a concrete diagnosis and really understand what that is? But some of the mediators to these barriers and the types of services is, what is the quality of the providers? What is their cultural competence level? What's their knowledge and communication skills like? Do they exhibit bias or stereotypes? And then also, what's their efficacy when it comes to treatment? And are they fluid and flexible when it comes to the different types of treatment options that they offer to marginalized populations? And then lastly, when it comes to outcomes, we look at health status. We look at mortality, morbidity, well-being, and also functioning as far as quality of life. And so what we're wanting to do is reduce these barriers and once again, these mediating factors that impact these outcomes. We want to have less mortality, less morbidity, increased well-being, increased functioning. And so when we look at the equity of services that patient views of care, they look at their total entire experiences. They look at the satisfaction of that experience, and also is there collective partnership, an effective partnership with their provider. So as we talk about substance use disorders, we have to kind of start with the foundation of, for many minority populations, the disenfranchisement when it comes to lack of treatment, when it comes to access to drugs, started with, well, didn't start, but once again, it was propagated with America's War on Drugs that was coined by President Nixon in 1971 and later expanded by Reagan in the 80s. And so both Dr. Elbert and I are 80s babies, so we remember this war on drugs because from that we had DARE, Say No to Drugs. From that we saw, once again, increased presence in certain neighborhoods. And so this is the unique part that one of the people who worked in the campaign for Nixon stated. He said that the Nixon campaign in '68 and the Nixon White House after that had two enemies that it focused on: the anti-war left and Black people. We knew we couldn't make it illegal to be either against the war or Black, but by getting the public to associate the hippies with marijuana and Blacks with heroin, and then criminalizing both heavily, we could disrupt those communities. We could arrest their leaders, raid their homes, break up their meetings, and vilify them night after night on the evening news. So did we know we were lying about drugs? They said, of course we did. Because don't forget this biggest hypocrisy when it comes to this war on drugs. One of the most significant terms that was coined from this era was the crack baby. And there was no scientific evidence to prove any type of epidemic of this crack epidemic when it comes to the babies. What we saw was this one article that exploded into the media and went rampant. There was multiple studies that have once again vetoed those 2 or 3 studies that came from the initial one that says that once again there was no type of characteristics associated with babies born during a time of where the mother once again was actively using crack cocaine. But once again, that propaganda showed this, and many women not only just went to prison, but they lost their children. And once again, there were a few that was also subjugated to once again infertility and going through once again castration when it came to them being convicted of these different types of crimes. So from this era, really understanding our student population, we got to understand, what type of students do we have on our campuses. We have to understand their homes and their community. So what we know is that people of color experience discrimination at every stage of the criminal legal system. and they're more likely to be stopped, searched, arrested, convicted, and harshly sentenced, and saddled with a lifelong criminal record. And once again, we know that having these criminal records also impacts their right to vote, their ability to receive sometimes public housing and public funds. And so once again, it's systemic and also systematic. What we know is that 1 in 5 incarcerated people are locked up for drug offenses, with the majority of them being Black and Hispanic. And similarly, drug and immigration offenders combined make up over 50% of the total federal prison population. So what about the children that we see on our campus? What we see is that, 1 in 13 Black people of voting age are denied the right to vote. 1 in 9 Black children have an incarcerated parent, compared to 1 in 28 Latino children and 1 in 57 white children. So a lot more Black children, then another significant amount of Latino children when compared to white children. So there are, once again, this focus on lack of parents in the home of many minorities, but this is one of the major contributing factors to it. And of course, the increased stigma associated with seeking substance use treatment in communities of color. So how does this show up once again when we're looking at substance use treatment on our college campuses? We look at it when we have to be able to look at collegiate recovery and the issues that we see within collegiate recovery from a root work and also social justice lens. And so we have to begin to redefine and possibly focus on when we're doing the 12 steps and how that's integrated into many of our CRC programs. And so there's some core issues related to the 12 steps that we could talk about. The first one, step 1, the role of powerlessness. We have to be mindful that we need to put a different spin on the word powerlessness, because don't forget, with minorities, they don't want to be labeled powerlessness. They fought many different fights. They fought to get into higher education. And so that can impact their engagement and interest into substance use or CRC programs. And so we want to, once again, the impact of these isms. So we need to frame it so that members are looking at reclaiming their power over their lives and work with them in an empowering way. Step 3, the God problem. And the God problem with step 3 says, we have to be mindful that many of our 12-step programs focuses on Christianity. But when we're working with minority and marginalized populations, they have diverse religions and beliefs. And so we need to explore faith and the connection to the client's culture. And we need to be include impediments, for example, the church and gay people in those discussions. Also, additional discussions on how to respond to isms and turn it over versus taking actions. And we need to be mindful of the trends of religion. There's been a recent Pew study in the last year or two that shows that our Gen Zers and the other, what's the other Gen? So Gen Zers, is it Gen Xers? Okay. Those two populations, and particularly related to minority populations, there are, even if they stem from homes that was very religious, they're less likely to be religious compared to their parents and community. What the research from these Pew studies is showing is that they're more likely to be spiritual and having this belief in a higher power that I sometimes don't understand. So how do we make that integrated into my substance use treatment? A focus on personal responsibility. In general, there's no acknowledgement of the contributions of how systematic and systemic racism, sexism, heterosexism, or any type of ism is related to the people's problems. It's a part of those roots. And so we have to expect that this step to include people or institutions that have discriminated against them. There might be also major resentments, past abuse, trauma, and also God resentments. So how do we integrate that into our CRCs also? And then looking at step 7 and step 10, dealing with discrimination. We have to separate character defects from adaptive responses or isms. And so there has to be ongoing discrimination or ongoing microaggressions and how that might show up in our daily inventory. So we have to separate out what's wrong, separate out what wrongs need to be properly admitted to. How were they wronged? What power or what piece did they play in that? Because some of it feels that it was they were directly impacted upon in relation to their causes to use, and once again what got them into full-fledged addiction. And lastly, finding self-reflection in group members. This is a common thing that we hear. The common thing that they hear is like, I have to feel like who I choose to show up as. And so the example given here is that I have to choose to be either Black or gay, and I have to go to the meeting as either being Black, straight, or go to a meeting as being all white and gay. And so once again, we know in this intersectionality, they can be all of the above, but oftentimes in our certain spaces of collegiate recovery, it's not as inclusive when it comes to race, culture, religion, and also sexualities. We also need to be able to provide alternatives to our collegiate recovery systems and programming. We need to have, when we're talking about these daily meditations that we typically encourage those in active recovery to be mindful of, are they once again population specific? So instead of just sending them to some, once again, the Blue Book, there's other ones that they can use. They have Black Pearls for African Americans, Glad Day for the LGBTQ, and then once again, Color of Light for HIV and AIDS, Keepers of Wisdom for older adults, Beyond Belief for agnostics and atheists, and the list goes on and on and on and on. And so we have to be mindful that once again, we have to cater our treatment and what we offer and recommend to be client specific. And then there also are some alternatives to 12 steps, which is very heavy laden with Christianity and religion. And so you have GABES, you have Beyond Belief, Humanist 12 steps to a realistic recovery, secular organizations for sobriety, White Bison, Wellbriety, Buddhist 12 steps, then the Free Thinkers steps. So again, there's, as we often say in the field, there's many routes to recovery. Are you offering the many different routes to your students? And what we know is that, one of the most difficult parts in working in substance use for so long is that, many minority populations are not offered the multiple routes. So for example, as we're right now in this active, very prevalent opioid epidemic that you hear so much in across the country, is that, we're looking at the roads to recovery. We have detox, and then we also have medication assisted programs. Are these programs, medication assisted programs, offered on your college campuses? Do you have physicians available who are, once again, not you can license in prescribing methadone and Suboxone and Subutex, on your college campuses? Because what we see in the outside, in the community-based organizations, is that minorities are 3 times less likely to even be offered alternatives outside of methadone. That's typically what they're only referred to. They're not offered, once again, lower addictive alternatives and medication-assisted therapy for their opioid use disorder. So again, we have to once again have access and equity to all types of interests into treatment for these populations. Dr. Elbert?
So we're going to transition and do a couple of slides around the intersectionality around mental health, COVID-19, and social justice. And I really want to emphasize, if you have questions, feel free to put them in the question spots. I got it pulled up, and so I'm tracking things as we're going. And so as we transition to this next slide, I want to talk a little bit about what we've been seeing around the COVID-19 pandemic and how it has widened the gap. And so there was a white paper that just came out. It was shared amongst me and some other colleagues, and this is from the white paper. I could put a link to it in the chat box once I transition it back over to Dr. Watkins. It said that 70% of presidents and chancellors at institutions of higher education identify that student mental health as among their most pressing issues. Another 66% of presidents reported an increase in the utilization of mental health services, with 59% reporting having invested in online or virtual services. And then we also saw that 70% of students of color using mental health services have found the services more difficult to access since the pandemic. But I really want to kind of track right here for a quick second because we've been talking about mental health in higher education for well over a decade. So to see this come out in a white paper that just came out this week is a little bit interesting for me because I think the newest thing that the 66% is surprising. I'm happy to see the investment in online and virtual services because I know my sister can add to this, but a lot of therapists prefer the face-to-face modality model. That's how they were trained. That's how they learned in school. And so there were some therapists, social workers who were adverse to moving to an online modality model, while some who welcomed it based off their own values and fears um, around COVID. Tatiana, I'll pull up the white paper in a quick second and I'll put it share it with you all. But it was interesting to see the numbers come out, and I was like, this has not been a new topic. We've been talking about mental health since, unfortunately, Virginia Tech, and we have really poured money into mental health in higher education for the past decade. Meaning, as a colleague of mine said on a panel we were on for another early this year, they said we've been trying to hire ourselves out of this crisis by hiring therapists, but we haven't approached it from a holistic model. But I had a conversation with a couple of directors who wanted to to ask me some questions around their health promotion, health education offices, and I said, well, how big is your office? Walk me through the history. And most of these offices are still 1-2 person led. Majority of the work being done by unpaid students. Majority of the work being done by this small but mighty group of people. The office hasn't grown since inception, but you've poured money into hiring 4, 5, 6, 7, 8, 9 more therapists, but you haven't adjusted to address the prevention side of it. And so that continuum of care has to be approached holistically and collectively. Do some campuses need to have a better student counselor model based off ACUD, which is, I think, one therapist to 1,500 students, 1 to 1,500 students? Absolutely. But if you haven't hired any health educators or medical providers who can write the scripts, you still haven't addressed the problem. You haven't, in the word of public health, went upstream. And so when I saw this in the white paper, I said, well, did they do any root work? Was any of this an issue pre-COVID, or was it just exacerbated? Because what we saw with COVID was an emphasis in what we saw when we started to be mandated to do more education on what services were available for interpersonal violence. We saw an increase in education about what access students had as far as student advocacy and what the adjudication process looked like, and we saw more students report interpersonal violence. We did the same thing for COVID. We did more outreach about what we had to offer. We partnered with a lot of the third party organizations, and guess what? More people utilized it. No surprise there. And so again, when we start having these white papers come out and we start seeing students of color utilizing it more, it didn't shock me, because guess what happened with contracting with these third party entities? Something good did come out of this. These third party entities actually hired more multilingual, multiracial, multi-ethnic providers that our campuses have not, could not hire. So now students were able to go online and, for some of these companies, choose a provider who looked like them, who could speak to them in their native language and tongue. What we started to see was a shift in our students of color who could do virtual therapy with their cameras off and have some anonymity behind the process of trying out something that was considered taboo, scary, that we didn't provide on our campuses. Because guess what? Some of our therapists and counselors did not ever want to offer that modality and that model virtually. And so when I see this offered, it doesn't shock me. So let me pause for a quick second. And Tatiana, can you see this on the screen, Dr. Watkins? So this is the white paper, Tatiana. And for those who are here, it is here it is, supporting student mental health through uh, a peer-to-peer community, a cornerstone to DEI. It came out through Together All. Let me see if I can copy this. I can, and I will put it in the chat box for you all, and so you all can look for it. But this is the white paper. We've been talking about it for the past week. Exciting. It has some good stuff in here, but it also has some things that we're like, wait a minute, they didn't dive a little bit deeper. So I'm not going to say the whole paper is bad, but I'm saying that some of this stuff wasn't shocking. And they have some things in here that we didn't put it in the PowerPoint, but at the last page, it has some things about how to address mental health specifically for BIPOC students. I think it's probably one of the best ones I've seen. And so I want to emphasize that as an option. So let me put that here. Yep, and there you go. So as we transition, let's talk a little bit about that feeling blah, the languishing conversation. Again, new word came out of the pandemic, languishing. It became the hot topic in a lot of conversations around mental health and COVID, and that it emphasized that mental health is existing on this spectrum of depression to flourishing. We've known that for quite some time. But now they started adding this extra, I call it that murky middle of languishing, of kind of feeling like the blah of I don't feel well, I don't feel bad, but I'm kind of like, eh. If you had an emoji, it's probably the one that's like, eh, type of emoji. When it comes with a sense of stagnation and emptiness, not quite depressed, but not definitely thriving, feeling your best self. It is what they said based off of this, the height of the pandemic and social justice, there were, people were more than 3 times more likely than their peers to be diagnosed with PTSD. And then the flow is one approach for easing a sense of languishing. And so I'm going to transition and go a little bit deeper into this. And when they started to talk about what was coming up for those who were experiencing mental health concerns or in the midst of the murky middle of languishing, this is what they were feeling. Feelings of despair, fear for their loved ones, decrease in job security, increases in loneliness, the mindset switched from thriving back to survival mode, chronic survival mode for some Black and Brown populations and poor populations, increases in alcohol and substance use, unhealthy eating patterns. We started seeing this shift start to happen. But one thing I didn't put up here, and I can't forget to shift this, is the population who were women identified having to make a drastic and rapid decision about how to deal with childcare and work. And we also saw in the midst of this exit of many of our women identified child care givers leaving the field, leaving the workplace, of having to make some drastic decisions and going back into survival mode and having to take care of their family, knowing that it may put them in a financial constraint. And so we started to see that also on our campuses of students having to make that decision to either leave our institutions of higher education. Many saw their enrollment numbers drastically drop. Some saw increases, but many saw decreases in enrollment. And so many campuses had to come up with ways to try to reach out to students to get them to re-enroll, to address why they wasn't coming back. Many campuses paid off looming bills that hadn't been paid off. So yeah, it has been a long-standing issue that campuses had to finally start to address. And so when they started to look at mental health and substance use and abuse, kind of on the back end of some of this COVID conversations, they started to say, all right, what recommendations can we start to look at when it comes to mental health and substance use? We needed to find ways to connect our own campus services and supports and start to strengthen our referral pathways. And so one of the things that we've done well in higher ed is our peer-to-peer programs, peer education programs, tutoring programs. And so now you've seen some campuses take that a step. And so a lot of those peer-to-peer programs did a lot of the COVID education, COVID COVID watch of, hey, peer, can you put your mask on? Or, hey, kudos, COVID programs, those type of things. Trying to identify and train some gatekeepers and doing some of this work. So you started to see some of those approaches that we did in peer education come over to COVID, and now we're redeploying those back into mental health and substance use and abuse. We started to really try to tailor our approaches to specific populations because we started to see things that uh, hadn't bubbled up to the top. When there have been campuses who never really tailored outreach and education for specific populations, they've now had to, because now students are saying, we don't want you to just come and do a presentation. We want you to come and do a presentation tailored for our population. Or what I've heard a lot of from my peers of, do you have a person who identifies with this identity and can they come and do this presentation? An increase in students asking for a specific identity-based therapist or clinician, and campuses saying we can't do that because if that happened, then that person will be overwhelmed and having to find a way to address it. And so we've now to start seeing that shift of a need to recruit diverse faculty and staff and counselors and therapists and preventionists to do this work to support our diverse student populations. And so I want to kind of dive into what DEI can look like within the largest scale. And so within that same white paper, I like how they break down DEI within higher education. And they talk about diversity being the range of human differences to describe populations, not individuals. Perfect way to describe it. They talk about inclusion as being about creating a meaningful sense that people are valued. It requires intentionality and engagement so that all people, students, employees, community members, experience a sense of being valued for who they are. And then equity is about providing equal opportunity combined with an understanding of the systemic barriers and biases that can make it difficult for individuals to assess and optimize those opportunities. Increasing funding to hire additional counseling center staff may improve access to available appointments. However, the hiring plan must consider that BIPOC students may be more comfortable seeing a counselor therapist that shares their racial ethnic heritage. Again, all those things have to be part of the conversations. And so some other definitions to be mindful of is, health equity. What does it look like to approach it from a health equity lens? It's defined at achieving the highest level of health for all people. Health equity calls for focused efforts to address avoidable inequalities by creating fair opportunities for optimal health, especially for groups who have experienced social, economic, and political disadvantage or historical injustices. Looking at health disparities, a difference in health status, health behavior, disability, morbidity, or mortality between socio-demographic groups. Health inequalities, a difference in health status, health behavior, disability, mobility, or mortality between socio-demographic groups, where the group with the highest burden or rate has historically and systemically been marginalized or discriminated against. And then social justice is one of several root causes of injustices, inequities in the health and the well-being of individuals. Social justice challenges the roots of oppression and injustice, including marginalization based on race, class, gender, and other social classifications, and empowers all people to exercise self-determination and realize their full potential through collaborative action. So when we look at health disparities and health equity, let's look at healthy people. So when healthy people first started, they was like, hey, we're gonna look at all health disparities across the United States. And in 2000, they said, we're gonna reduce health disparities for all Americans. By 2010, they said we're gonna eliminate, but not just reduce it. But we want to eliminate, not just reduce health disparities. And then by 2020, they started to go even further and say we want to achieve health equity, eliminate disparities, and improve the health of all groups. And so in healthy people started to define health equity as the attainment of the highest level of health for all people. They knew they had to keep going a step further, and a step further to really address what was impacting those Americans who were being impacted with their health. And so then we started to have some necessary conversations about, all right, how do we do this? And so I wanted to start a kind of pause about what does it mean to be non-racist, because a lot of times when we talk about addressing health equity, health disparities, health inequities, we have to look at it from using appropriate language and words and usage. And so the term anti-racist refers to people who are actively seeking not only to raise their consciousness around race and racism, but also to take action when they see racial power inequities in everyday life. And being anti-racist is much different from being non-racist, according to James in the research that they did. And then kind of looking at it from the next perspective, what does it mean to be non-racist? Being a non-racist means that you can have beliefs against racism, but when it comes to events like the murders of Black men, Black and brown men by police, you can watch things at home unfolding on TV, but not do anything about it, say anything about it, not address it with your peers. But being an anti-racist means that you are developing a different moral code, one that pairs a commitment to not being racist, whether verbalized or not, with action to protest and end the racist things you see in the world. And how does that look for those of us in higher education? It may be supporting our students of color who are demanding and asking for things that they feel are necessary for their ability to thrive on our campuses. It may be demanding for more faculty and staff that represent their identities. It may be asking for more prayer rooms. It may be asking for things to be added to the syllabi. I don't know. But to say that we are going to address it, it means that we can't just stand idly by and not say, hey, we need to do something about it. And you can even start to address racism and say able-bodyism. You know, it's always important for me to think about, now that I'm back in another town where there's snow, I always think about when the snow is not shoveled, how are our students who are not able-bodied or able-bodied somewhat but may need assistance through a walker or other tools, what it's going to be like to walk across our campuses and they haven't been fully shoveled or de-iced. I mean, you can take this approach for other areas and approaches and not just look at it from a race ethnic background. And so ACHA, American College Health Association, has a framework of how they look at college health programs, but it supports the universal principle for being actively involved in the diverse communities of our campus by ensuring that all students have convenient and equal access to timely, high quality, affordable services, regardless of the program's size or scope of services. And for some, it may be a really great referral program, access to a third party entity, through a MOU in the community. Some of this may not be housed on your campus. But when you're looking at it on your campuses, this is just some ways to look at it from a data perspective. You can look at your staff climate surveys, student climate surveys. If you do the NESI, enrollment management data, the NCHA3, National Collegiate Health Assessment, your campus partners do listening sessions, parents and families listening sessions, any student advisory committees, student orgs, patient satisfaction surveys. And so you have multiple avenues to kind of glean and take in data and information to get what you need. So I want to emphasize the importance of using multiple data sets to help inform decisions that are made and not just have one set of data. And for those who are leaders by title and leaders by work ethic, these are some things to think about it from a diversity-driven leadership model. What is your EHR, EMR looking like? Are pronouns able to be added into the electronic health or medical record? Because sometimes we take in the information from our enrollment management office, and so it has their given name, not their preferred name. But is there room in there for students to edit that information? Is there access to language interpretive services? Is the facilities welcoming and inclusive and accessible, bathrooms wide enough for wheelchairs and different things to get through? Does your campus participate in the Campus Pride Index? And so that's how you can provide culturally competent care and services. Do you make it known through your strategic plan, mission statements, email signatures, she, her, hers, using the pronouns, display pronoun ribbons, make it known through visually on your website when you list the names of your leadership team? Does your leadership team represent the diversity of your campus population? Increase campus representation of diverse students, faculty, and staff through your recruitment, retention, onboarding, and position descriptions. That's a whole different presentation just by itself. And then do you walk the walk? Through leadership expectations, dialogue, getting comfortable with the uncomfortable, and professional development. And I always say it starts from the top. And so let me give you an example of how I walk the walk when it comes to leadership expectations. I add extra work to my plate. I sit in on as many interviews for my team. So if they bring in 3 candidates, 4 candidates, I ask for no more than 30 minutes with each candidate. 15 minutes minimum, 30 minutes at most with all candidates. And they were like, well, you just want those in leadership, like assistant director up. I said, no, all staff. I don't care where they are in the org chart. I have an open door policy. Anybody can meet with me. I do exit interviews if they choose to. And so I found a way to engage in multiple avenues to engage in and answer questions about leadership expectations, the culture here, what we are, where we're going. And they get to get it from the time they interview, and I get to get it on the way out when they leave to hear if they experienced it during their time here. It starts as far as how you set up the structure as a leader. Sorry, I went the wrong way. So it is an ethical obligation that we do this work to serve our diverse student populations. We have to. Um, we know that race or ethnicity, sexual identity, age, disability, all those things contribute to an individual's ability to achieve good health. It's important to recognize the impact that the social determinants of health have on outcomes of specific populations. And we know that's been in the Healthy People document. Aggregation masks what is really happening at the individual level, and progress should be measured by improvement made among the most vulnerable of our populations. Um, and so if you're not disaggregating your data, you're not going to be able to address what is happening with your students. The attainment of the highest level of people requires valuing everyone equally with focus and ongoing societal efforts to address avoidable inequalities and contemporary injustices and the elimination of health and healthcare disparities. And I already talked about this aggregation, but we see a lot of campuses not having the time, the expertise to really do some disaggregation of data, and that really can help you take that deeper dive to address it. And so as we look at some basic principles about diversity, know that some of your students, even some of your colleagues who represent diverse identities, may come in and that there may be some distrust already in existence and they have nothing to do with you. And so it's going to be imperative that we don't get defensive. And that can be with any diversity category. Understand that it's going to take some time to establish trust, and that it's going to be patient. But I do remind my staff that this is not the day for you to show up and have a bad day and go into a community that we've just got the first chance to go in and be introduced to and start to build relationships to have a bad day. That's the day you call in and take a mental health day. And so sometimes you only get one chance to start that beginning of a relationship. And so we want to do our best each and every time when we're working with these populations. Good health is not necessarily a priority in these communities. For many of these communities, coming to campus, coming to university is the biggest priority for them. Graduating is the biggest priority. Oftentimes, their health is not even a thought, but how do we engage in those conversations while they're matriculating on our campuses? And as health and wellness professionals, we are the gatekeepers, which gives us the authority to assist in restoring that trust. And so don't take it for granted. We have many opportunities to do some of this work. Dr. Watkins, do you want to take a small break before we transition to the next section?
Yes, let's take at least a 6 or 7 minute break and then come back maybe like at 2:52.
Sounds good.
Okay. All right, we're going to gear up to get back started. Dr. Elbert, do you want to start with any questions? Anything come in recently? Okay. So again, we're going to start off with a question, and you're welcome to add your comments to the chat box or to the question box, or once again, kind of just add it to your list of intuitive questions to take back to your institutions. So the question states, what are some examples of how systemic racism, so we're looking within the system, is seen in student health services, counseling, and psychological services, health education and promotion, and collegiate recovery programs, and also campus recreation. So we've defined what systemic racism is. We've provided a few different types of examples. Now the question is for you to answer. What are some examples of how systemic racism is seen in these various different types of what we term, health and well-being offices and departments? So I'm going to provide you with a few different examples related to health services and counseling services, but I'm also going to let Dr. Elbert focus on the ones with health education and campus rec, since those fall up under her purview as being Associate VP. So what we know when it comes to systemic racism in health and wellness is that it contributes to our current health disparities that you saw mentioned, that the World Health Organization is trying to target and also decrease. Health and wellness related racial disparities in the U.S. include a couple of different things. The first one is deeply rooted, that's the word root also again, institutional racial biases that structure the experiences of all Americans. Two, the effect of racism-related stressors on the biopsychosocial functioning of non-white people. And the conscious and unconscious biases that shape behaviors directed at people of color, which is also including among prevention and healthcare practitioners. It is also important to recognize that systemic racism operates differently and has a diverse effect on producing health disparities in different racial groups. These experiences often lead to, alienation, isolation, marginalization, and loneliness, which compounds the negative effect of already what's present as related to their mental health, substance use, or wellness issues. So how do we, when we asked the question a few slides ago about, how do we see systemic racism in our diverse offices, one of the best places to start is, do the providers and practitioners in these different entities exhibit cultural humility? Do they also receive training in cultural humility? So it is not enough to think about one's own values, beliefs, and social position within the context of today's society. In order to practice true cultural humility, a person must also be aware of and sensitive to historic realities like legacies of violence and oppression against certain groups of people. So we need to make sure that there's an education component to understanding certain groups of people. And one simple way that I used to see in my formal hospital setting that I worked in was they actually had an educational portal where we can learn about different cultures and how we can make sure we effectively communicated and treated them. So for example, we can type in any specific type of culture, and they would tell us was it particularly patriarchy or matriarchy, make eye contact, not make eye contact, their average or typical belief systems around the health system and treatment. And it was very good. Sometimes it would include videos and also sometimes links to other articles. And so it was a way for us to be able to have access and understanding at our fingertips in working with diverse populations and exhibiting that cultural humility and understanding their background.
So when we look at, what some of us in the public health prevention realm have been trained in, we looked at the measurements of looking at the social determinants of health. Um, and these are the conditions in which we live, we learn, we play, we age. And we've done this work for so long. And so if you look at it from the domain, as you see on the left-hand side, the integrated healthcare, community resiliency, physical environment, socioeconomics, and community trauma, you can look at the determinant on the right-hand side. So looking at integrated care, healthcare access, social services, behavioral health, within community resiliency, civic engagement, social vulnerability, equity, and policy. When you go down to social economics, housing burden, food insecurity, education, and even with housing burden is so tied to education because now some school systems have said you have to stay in their zone and you can't transfer from the outside in. And so some things have started to happen and change that is also impacting that. And then when we look at community trauma, discrimination, mass incarcerations, public safety, and even incarceration in some communities. I was watching a special on the incarceration of our youth. Um, and so we're starting to see things that are impacting our communities within a variety of domains. But I also want to give you a look at another way to look at how we can transition and use language very, very differently. And so when we talk about it from a very equity-based lens, we talk about the social determinants of health. Could we mean health outcomes due to systemic forms of racism and oppression? When we talk about Black, Indigenous people of color are at higher risk for, can we actually mean racism increases the risk for fill in the blank? When we talk about diversity and inclusion training, discrimination and systemic racism awareness training, implicit or unconscious bias could actually be racist beliefs that I hold that contribute to oppression. And then last but not least, calling patients drug seekers is really not having a racial empathy gap and failing to acknowledge and treat the pain of Black patients. And then looking at it from another perspective of what we say and looking at it from the actual problem around social determinants of health implies that people do not actively invest in the systems that the cause of health disparities, who or what is determining poor health outcomes. And again, some of these are systemic and structural, and we don't have the same impact on those systems. And when we say Black, Indigenous people of color are at higher risk for, is race the risk factor is racism. The medical field needs to really call out racism for what it is instead of implying that health risks are independent from systems of oppression. And then last but not least, looking at calling patients drug seekers contributes to the racial empathy gap. Black patients are less likely to receive pain medication than white patients. And they continuously do the same study over and over again, asking new medical providers about pain when it comes to people of color, specifically Black patients. And they still believe that for some reason, Black patients can experience pain at higher disproportionate levels and that they don't need medication and that they're drug seeking, even though the data is completely opposite of that. And so we see even with the new data of incoming practitioners first and second years that they still believe a lot of the things that have impacted the field. And so we will look at treatment and care. I want to kind of transcend and look at one of the things that I learned early on in a presentation I went to years ago, the crash model, looking at a way to consider the culture, respect the culture, assess and affirm, assess the situation, affirm their beliefs, affirm their culture, be sensitive and self-aware, and be available to have a sense of humility in how you engage in this approach, which is again using the crash model. But we take it a step further and look at it from being culturally competent in our care and our approaches with these with students and and those we serve. Um, sorry, you want to have the ability of any healthcare provider of any cultural background in one's organization to effectively treat any patient of any background is where we strive to be when it comes to cultural competent care. Substance of respect for differences, continuing self-assessment regarding of culture and any other identities, attention to the dynamics of difference, ongoing development of cultural knowledge and resources. And the vision can really be around that diverse families and students and people thrive. And they participate and contribute to healthy and healthier communities if we give them the chance to. And so community and ethnic based organizations and networks, knowledge discovery centers and national facilitation centers can be a big part of that. And for us on campus, it can be some of the student organizations that are identity based. Equity in care is inadequate, is as equity in care is an inadequate outcome for a lot of the approaches that we're trying to do to really be innovative. Rather, transformation is needed for behavioral health focused on culturally and linguistically competent interventions. And if we can't get to that transformation, then we start with equity first. So, some guiding principles to cultural competence: increased access in primary care settings and non-traditional facilities. Increase should be an increase in screenings. Again, because this may be the primary way students get access, and so that will be through our student health centers. It could be if you have a student advocacy office, uh, if you have a food banquet or food clinic that helps students, clothing closet. They may be coming to those areas versus through the counseling center. So how you do screenings in other areas can be very, very helpful. Having screenings accessible online can be helpful. We have some screenings through our wellness app here at Ohio State. So our suicide prevention office has some assessments available through their website. So the more you make the screenings available, the better students, when they are ready, can take the assessments and then get the next steps on what they could do. Um, and also making sure you include prevention in your approaches and as far as cultural competence. And so when you look at diverse populations, you want to look at linguistic components. You want to look at ethnicity and cultural components to how you approach to work with them. When it comes to cultural competency, you want to be effective in your techniques of engagement. You want to have sound implementation. And hopefully, as you're doing this, they're all part of the process. They're part of the planning team if possible, or at least informing you all as you're doing this work. From there, you can then have appropriate services for these diverse groups when it comes to preventative screening, diagnostic, and treatment. And then from there, you impact the outcomes for these diverse groups: health status, functioning, satisfaction, and then long-term outcome is the reduction of health disparities. But when we do this well on campus, we not only prepare them to be good advocates for themselves and when they become consumers of traditional healthcare, what we also know and what we don't track enough of is how they take this back to their communities back home and their families and their social circles, in which we know they do that. And so what we also don't see is that reduction of health disparities, um, and how their circle, their family, their community is being impacted by how we're doing the amazing work that we do on our campuses. So I want to emphasize that also. So I'll start off with some things, and then I'll let Dr. Watkins share. But implementing culturally competent programs and services is more than having someone on staff who is bilingual or who looks like the targeted population. Because one of the worst things to do is to bring them on and they're the only. And it happens so much. You don't want to just bring them on. You want to have a culture, you want to have a climate that welcomes them, that affirms them. And then if you happen to not have anybody else that they identify with, that you brought them to your campus and during their interview process, they were already able to engage with them during the interview process so they can build community very quickly when they get here. You arrange for them to be able to meet with them as part of their onboarding, even though they met them during the interview process. You build it so that way you're bringing them in to provide specific catered and tailored services to these students, but that you also don't isolate them. When I talk about how we do this for students, we recruit these students to our communities, but we don't have the services. And so I did a presentation on recruiting and retaining staff of color, and I also emphasize how that impacts our recruitment of students of color, specifically peer education programs. And one of the things I talked about that was hard at my previous institution was that there was no hairstylist within a 2-hour drive of me. And so for 2 years, I couldn't get my hair done unless I was able to drive 2 hours over a mountain pass to Seattle. My husband was the only barber until one of the other students started cutting hair. And so what does it mean to be able to, have some time to sit in a chair and get pampered? What does it mean to walk into a store and your products are actually for your hair, for your body, are actually in the store, and not at the back, at the bottom, in a section as small as my desk right now? And so I think it's important to be mindful. It's not about just recruiting the students and the staff and faculty to our campuses, but you have to be prepared to welcome them and have resources and services for them. And so, along with that, it's better to take the time to conduct the assessment to learn the strengths and areas of growth that might impact the outcomes. You never want to go dive head first into a needs assessment or a climate survey or doing environmental scan without actually taking the time to get the structure of your approach, build the needs assessment, have the right team to assess the outcomes, and planning from there. Because failure to assess could result in unplanned failure. And we've seen that happen time and time again. Anything you want to add, Dr. Watkins? And last but not least, my favorite, take advantage of teachable moments for both staff and clients and participants in our programs. And Hyam, I see that you have a question about screening tools. We are going there. Dr. Watkins has a whole slide. Just hold on, it's coming. And then last thing on this slide, include student influencers in your program activities. Just don't ask them what they want, include them in the entire process and make them part of the program. They then become the key stakeholders, and they continue the program, they pass it down. Some other lessons learned, make sure you address the decades of violence, poverty, stigmatization, and widespread incarceration and general substance use. I would say probably 3 or 4 years ago, I got the ATOD award at American Public Health Association's national conference in Atlanta. And it was such a big moment for me professionally in my career. But I started off my acceptance speech by saying it was bittersweet because I am an outcome of the 80s crack epidemic. Our father's addiction had him incarcerated for most of our childhood. He didn't have access to treatment and recovery like we were trying to do, and we have done for the opioid epidemic. Um, and that's how I opened my speech. And there were so many people there, and I didn't know there was somebody there from the White House. And I said, it's so bittersweet that I get this award. And I went into this field because I did it from a place of being angry and not understanding why he didn't have access to support. My sister became a substance abuse therapist. We just didn't understand it. And so, it's not enough to do a land acknowledgement. Um, you can't do a land acknowledgement without also acknowledging that there were slaves and indentured servants who built many of our institutions. You have to do both. And so I think we have to be very mindful on how we approach this, and be sensitive to knowing that many of our students have come to college, but their mind is still home, worried about their family, dealing with the day-to-day trauma, violence, stigmatization, poverty that's going on at home. And then I'll let Dr. Watkins covered some of the bottom slides when it comes to addiction treatment within primary care and some of those things.
And so when it comes to addiction treatment, and it also is inclusive of mental health treatment, we have to have an integrated approach. So I would say in my career, I saw this movement start probably around 2012, 13, maybe a little bit before, we can say at the earliest 2010 that I remember. We saw this big wave and immersion of integrating care management, mental health, and then later, a couple of years later, substance use, especially, particularly with the expert model, into integrated care. And then we saw it also go into case, as you see, case management, and then into infectious disease. I saw it pop up. I was actually one of the first directors over a behavior health program in an infectious disease department at Brody School of Medicine. And so I got to create it from the bottom up. And it was one of the first ones that was also up under a Ron White funding institution. And so it was amazing to see this integration and that I was a part of this new dynamic that was rolling out. And so we also now see it in gynecological and other specialty services, cardiovascular, and also, once again, in behavior health services, having different entities within behavior health. So no longer did we just have psychiatrists, psychologists, and also therapists. We also begin to see case managers, peer support specialists, qualified professionals, associate professionals, because each one can have a major impact in, once again, engagement, intervention, and also retention and care. And so when we're talking about the integrating of care, you know, it can be tricky, especially within the community model and also higher education, if there's not any type of cohesiveness. If everyone really doesn't have respect and understanding of each person's role, but also understand, most importantly, where it may overlap, that can also be a barrier to integrated care. Training in unconscious bias and stereotyping, cultural humility, person-centered care approaches that have enhanced social and structural determinants of health components are also important. And this is definitely important because we saw also a massive wave in the late 2000s that focused on in-community and in-home care for substance use and behavioral health services. And so there had to be some training in unconscious bias and also cultural humility and person-centered care when we're literally providing care up under bridges, in mobile homes, on farm tracks. Once again, especially working with some of our migrant farm workers, and then once again going into some of the projects. And so, how do you be present once again when working in those different various environments? One of the most simplest things that I learned when I was became a first-time clinical director in teaching my new graduates and my interns was, you know, we're walking into homes that sometimes may not necessarily have running water or lights. We're sometimes walking in homes and once again that the hygiene and upkeep may be different than yours. But how do you still be present without screaming, without itching, without, you know, making funny faces? And you have to now educate that. That's not in the textbook. So you wear long pants, you wear socks, closed-toe shoes, you wear long sleeves, you can wear a hat, because once again, sometimes, you know, the roaches fall from the ceiling, but you don't flinch. And then once again, when you get to your car, when you get to before you walk into the house, you know, we talked about, you know, stripping and all that type of stuff, because we have to be present for our clients. They need us regardless of what their homes look like, regardless of what they do and don't have. And it's no different for many of our health centers. I remember in some of our health centers that I would hear, you know, this student brought in, you know, roaches, or this student smelled a certain way, or this student once again said this. And we don't know the homes that they come from. We don't know what they were, and we're not taught. So how do we just be present and show up? And once again, most importantly, going back to that first slide, create spaces for them to be. How do we evaluate and determine effectiveness of evidence-based practice? And most importantly, who determines evidence-based? Because when we go back and we look at history of everything that's evidence-based, especially within psychology and psychiatry and the medical model, it has been cisgendered white males. It has not been catered to women. It has not been catered to minorities and marginalized populations. And so once again, we have to go back and look at, you know, the structure and the very foundation of many of our reforms. And we have to be able to, once again, throw out the model, sometimes use the model when appropriate, and sometimes be creative and combine it with other different types of approaches. Collaborating with and working with within the communities is also something you have to have, that duality, because within higher education, we're sometimes limited on the amount of time that we can work with mental health and substance use issues. So you need to have community liaisons on which you can refer them out to for long-term care and sometimes higher continuity of care.
Sorry, Dr. Watkins.
Mhm.
So when we look at equity-based interventions, we need to make sure that when they seek to improve health outcomes in these what we call sometimes subgroups or targeted groups, they are already disadvantaged, and the goal is to improve their overall situations. And coming to college is a great chance to do that. So we think about. I was talking to one of my students who's in my methods and evaluation course down at Tulane, and she's working on dental hygiene as her major project for her program plan. And I said, I remember in elementary school we used to get those little white cups, and we used to have to swish once a week. And that was part of the dental hygiene because we know that the chloride washes was part for those who didn't get consistent access to dental hygiene and dental care. And so, when I talked to this student, I said, they don't do those things anymore. So how do you create a program plan for your specific population? And her population is rural. I said, so how do you do that when your population is still using a lot of well water? The well water is not being tested on a consistent basis. And so just asking those questions. But guess what? Those are the same students who are coming to our campuses. And we don't even do that same type of health education. We think they came to campus and they are okay. But guess what? Some of them did some, while we know a good population of students have been in consistent counseling weekly, bi-weekly, for a long period of time based off data. We also still have populations of students who didn't have consistent access to any type of healthcare, let alone doesn't know what prevention looks like. Some couldn't even work out. So you ask them to come and join our recreation facilities, to go on our outdoor programs. No. So when we look, when I talked to some of my recreation staff about equity-based interventions, and they were like, we want more of our students to do rock climbing and go on some of our outdoor programs. I said, do you know they couldn't even walk in their community? So you want them to start doing some of the programs that require them to go outside? Do they have the shoes? Do they have the clothing to do it? Is this something of interest? Same thing for water aerobics. Do you teach these students who have kinky curly hair how to prep their hair? They now have swim caps now for those who have kinky curly big hair, but they used to not to. And so we've started to see these things evolve, but for years they didn't have it, and they used to say, well, these students don't come, so we won't have programs for them. And same thing for weightlifting when it comes to recreation. A lot of recreation facilities started to say that the weightlifting area could no longer be the big buff area. You couldn't be screaming and making grunting noises. You can't have your shirts off. You got to have a shirt on. Um, those things have started to shift. So they started to say that this is an area where all students are welcome. And I've met some campuses who've created physical spaces, recreational spaces outside of the rec center for those who are not comfortable quite yet. So we look at interventions. We want to make sure that access is not limited to actual physical space. We want to make sure that as we look at how we approach prevention from that continuum of care, we're looking at it from a very holistic perspective. We know that interventions that do not have an equity focus may inadvertently exacerbate inequalities, even when national averages indicate overall improvements, because your specific population, if you don't disaggregate your data, may show that they're not getting the benefit of it. And so we saw that with media campaigns. We saw less people smoking tobacco products, but we started to see an increase in vaping, hookah, with populations who would have never smoked any tobacco products. Surprise, surprise. But they didn't dive into that data until it was almost like, oh, wait a minute. We now needed to start doing some education for populations who think this is actually healthier. And there's no cookie or cutter approach to this. I think what we've gotten used to is, well, we've always done it this way. this is NIAAA, this is a best practice, this is what our national organization says, but what does your student population say? Can you meet them in the middle to provide a combination of both? It's not an either or, but both, to ensure your students are being treated from a whole person approach, because no single treatment works for everybody. And treatment and must attend to the multiple needs of the individual. And remaining in treatment for adequate time, and I'll let Dr. Watkins come in, is vital for the success, for not only the student, but what we see again is when they do it, when they take the time to start the treatment and recovery process and the healing process, that does start to, one, it shifts where they are and their future, and then their in their future generations. And then it also, if they choose to, it goes backwards, and they go back and start to impact their family and social circles. And so we start to see some generational shifts when it comes to health, and well-being, and access to treatment and recovery and healing. So treatment shouldn't matter regardless of race, ethnicity, socioeconomic status, but that's a longer conversation, because we know there are people who are getting high deductible health insurance plans because that's the only way they can afford it until something bad happens, and then they are really upset that they end up getting that high deductible plan. Some campuses have went to a hard waiver model of health insurance where all students have to have some form of health insurance, but even then, some students don't know how to use it. So we have to get to a better place where our approach meets the multiple needs of our individual students and get to the root of their problem. We must make sure that our staff are trained to deal with the diversity of our students. Our staff are as diverse as possible, as our students, and when not necessarily possible based off a variety of reasons, you bring in consultants, you bring in potential third-party vendors who help diversify your services and the access for your students. When we look at defining wellness, we've always looked at it from this kind of continuum. It's free from illness, it's a dynamic process of change and growth. And a lot of times when I talk to students around defining wellness, they have not even thought about this. They haven't thought about wellness, especially our BIPOC students. And so a lot of times I just emphasize that wellness is conscious, it's a deliberate action, it's a verb. That means you have to actually try to do something around this. And we center ours here around those dimensions of wellness, and many of your campuses can choose how you want to approach it. But the National Wellness Institute has a model around multicultural wellness, and they have a whole wheel. And so if you Google Multicultural Wellness Wheel, NWI, their whole website comes up, and they have some really good stuff around their redefining wellness. And it has some tips and techniques on how to address it for different identities that you may work with on your campuses. And I think it's a great model to start with for some of you all. If your campus hasn't started to have these conversations, this is a great start to look at it from a very holistic model. So I'll turn this over to Dr. Watkins, because now she's going to transition to some of the treatment and answer some of the questions you all have around the specific treatment components.
All right, so let's focus on addressing some of the conversation when it comes to treating the students, typically in the medical and also the psychological counseling settings. Some of the more important factors is really what the research tells us is that upon entrance, that very first appointment can determine whether a student comes back and also is maintained into counseling. And when they, what the research has shown is that there are a couple of things that is high in priority in which people of minority and marginalized populations have said that is very important to them is on this first slide. They said setting the stage is very important. And so some of the questions that they focus on is, what does the environment look like when I walk in the door? Is it warm and welcoming? Is it clean? Is the furniture of good quality and comfortable? And especially when it comes to those of different sizes, can I fit into the chair? Do I have to stand? Does the artwork and decor demonstrate your openness to different cultures? And also the same thing when it comes to the magazines and also brochures. Can I see myself and what is surrounded by the aesthetics and also by the reading materials in your office, your handouts, your brochures, your paintings. And then most importantly, did you greet them and how did you greet them? One of the most significant factors that I've heard from multiple minority students is, they didn't pronounce my name correctly. And then when they didn't pronounce it correctly, when I provided correction, they said, "Oh, okay, come on back," and it was very dismissive. What we know is that in many minority populations, their name has meaning, their name has purpose. And so to demean someone and says that, for example, I'll use my first name. I'm often called Shara, Shara, or Ashira. And I'm like, no, it's pronounced Sheree. Oftentimes we don't have the mechanism to put the accent over my A, depending on the different types of tools and things that I'm using for. And the students often say it was diminishing because my last name could be pronounced Brown, Hopkins, anything on those lines, but they attempted to state my first name that was once again cultural. And so when I corrected them, they didn't try to apologize and retry based off correction. And two, even if coming into the setting, they didn't know how to pronounce it, they didn't utilize another option. An option of I can pronounce this, and so I can use this instead to make my first contact with this patient or client. What does your body language say? Did you make eye contact? And then most importantly, how long was the wait? Because if I have to wait typically more than 15 to 20 minutes, sometimes they leave and sometimes they won't come back. So as we move from the intake, this intake is inclusive of both, again, healthcare and also psychology. The very first question that we ask is, what tools, screenings, and assessments, are being used? Because most importantly, typically in medical and also in counseling settings, one of the two most common ones to assess for anxiety and depression is the PHQ-9 and the GAD-7. Well, I actually did a study when I was working with sickle cell patients who have been living with chronic pain since birth. And what I found in that study is that the PHQ-9 did not pick up on depression because there was a lifetime of, once again, being in pain and being sad. And so what I learned is that I had to restructure how I assess those clients. I can still give them the PHQ-9 because it was a part of our policy and process. But I also had to go and ask follow-up questions, questions that was more related to our minority population, which is typically Black and Hispanic when it comes to sickle cell, about, once again, what was their daily life like? Tell me about any given day. How do you feel? And then once again, one of the key indicators that I ended up finding out is that I can tell if there was significant levels of depression based off of learning the client and especially learning about how their pain crisis would develop, the location of those pain crises. What did it feel like? Where was it located? Because typically when my clients would say they are in pain, and they were putting the location somewhere that was not typical of their past pain crisis, I had to dig deeper to the root. Is it that you are exhibiting physical pain that is associated with emotional pain? And for them, in their mind, pain is pain, but it's the same thing. I take my pain medications because I'm in pain, but is the pain exactly related to your disease of sickle cell, or is it related to your emotional pain? And so really getting them to dig deeper to the root. And then also when it comes to the tool screenings and assessments, once again, what does the study say about the validity of it being used with minority populations? Sometimes it's published and sometimes it's not. And within those intake, how do we define and redefine old questions to more culturally sensitive and humility questions? Old questions would be, in the home, actually tell me about your parents and what was home like. When there's an automatic assumption that both parents was in the household or they were even raised by their parents. And instead, we can actually ask better questions such as who was raised in the home with you and what was your experience like? Other things that we can say is, what was or is it like to grow up in your family, and how has that affected, your view of your family? How has it affected your view in relationships and how you see medical treatment, how you once again see mental health? Tell me about some of your traditions and your rituals, celebrations. What's your culture's perspective on mental health therapy and counseling when it comes to treatment of the disease? And what are things that your culture does to help with your sadness, anxiety, and bad experiences or other troubles? Because that can be incorporated in making a comprehensive treatment plan that can target this particular client. So we want to make sure the intake is culturally sensitive. And next, we got to talk about diagnosis. Unfortunately, there has been prior precedents of looking at marginalized populations across different states, across different countries, and even studies that focus on those who are incarcerated, where there has been an association of misdiagnosis of that was typically severe and profound when associated with marginalized populations. One study that always comes to mind is a study in a male prison that had higher rates of PTSD, bipolar, and schizophrenia among Black male and Hispanic inmates. And upon review, over 50% of those diagnoses was actually false. And so we have to be mindful of how do we culturally assess for these symptoms, because our DSM tells us that they have to meet X amount of criteria out of this amount of criteria. But once again, what cultural considerations can influence the diagnosis and care, can influence the type of symptoms that they may have? Because if you ask, how did your home environment influence, how you handle sadness, how you handle depression, how you handle anxiety, isolation, not talking, which may once again be indicators of certain types of diagnosis, was just actually a way of coping for them. So we have to dig a little bit deeper and go to the root. Are we using culturally relevant interpretations of social stressors and supports and levels of functioning and disability? What is the meaning and perceived severity of the symptoms in relation to group norms? So not comparing it to the dominant group, but to also the group, once again, that they can be associated and affiliated with. What is the role of religion and kin networks in providing emotional, instrumental support? And are these networks all involved with, once again, in relation to substance use? Are those networks and support systems also involved in drinking a drug? Because it's one thing to, once again, treat them, provide them with these skills and these tools, and once again, to get them into active recovery. But on spring break, fall break, and other breaks, they still have to go home into those same environments and communities and still have to learning to say no to drugs and alcohol. Self-medication for underlying depression, which may be biologically based and requiring antidepressant medications. I've seen, a lot of people say, I can't tell you why I've been depressed, but I've noticed that I've been depressed all my life. My earliest memory of depression was when I was in the 5th grade or the 6th grade. That's a common theme I've heard with a lot of my clients who exhibit moderate to severe depression that is chronic. And then also individual differences in culture and social status between the individual and the clinician. And also the clinician's experience with or without substance use as far as their own lived experience. And so we have to understand that if there are some cultural differences, some racial differences, some societal differences, is that, before you start this intake process, this diagnosis process, we have to address the elephant or elephants in the room. Some common mistakes that we see with medical and also behavioral health professionals is taking a colorblind approach to how they treat their clients and patients. By failing to see color, you not only invalidate their experience, but you also ignore an important part of who they are and their identity. And so we have to be mindful that in not seeing color, we also don't see an entire culture through the same lens. The burden of teaching also when it comes to do no harm should never also be placed on the client. It's okay to ask clarifying questions, one-off questions, just to make sure you have an understanding, to make connections, to once again have a good understanding of what's been shared. But it's not up for the client to educate the practitioner on their culture. And once again, those clients are not a representation of all people of that population. Gaslighting is the act of questioning and dismissing clients' experiences. One of the most tough pieces for me was this one in dealing and working with my sickle cell patients because I worked inpatient and outpatient with my clients. And I never forget, I had this tough client, was in and out of the hospital, recidivism rate, his hospitalizations was like over 50%. He literally would come out of the hospital, maybe be out a week, maybe two at the most, and be right back in. And with working with him and really getting to the root of some of his mental health issues, we was able to decrease recidivism. And I worked on coping skills. I worked on teaching him different ways to cope with his emotional, but also most importantly, this physical pain that would never go away unless, once again, through other methods that are out there for those who are eligible for it. And so I got a phone call from one of our mid-level practitioners that this particular client was crying, was hysterical. They were talking about calling security on this person, and I'm like, okay, just wait. I'm on my way. Just let me walk over into the hospital. Once I get there, I literally had nursing staff and medical staff saying that the client was being belligerent, the client was lying, the client was drug seeking, and the doctor was like, I'm discharging this person. He's been in here for at least 2 or 3 days. And so I said, well, let's pause. Just educate me. What are you seeing? And the client was saying, the client is, when I asked him to scale his pain, he's saying that his pain is literally an 8 out of 10. It's in this location, which is one of his typical locations. And he's describing the pain as he would typically describe it. But when I walked in, I saw him watching TV. I saw him on his phone. I saw him playing a game on his phone. And I said, okay, I'm waiting for the next part. And he says, if someone was in that amount of pain, that level of pain, they will be showing distress. And so my response to the nurses and also to the medical professionals is that, so you want to punish my client for me teaching him healthier coping skills instead of coming into the hospital for unwarranted pain crisis. And so he's utilizing those types of skills that I've taught him. And now you're saying that he's a liar because he's utilizing the alternative methods that I have taught him as a counselor, as a behaviorist. We have to be mindful that sometimes our perception and our biases can play a role in how we treat and how we show up. And one of the biggest statements that I always would treat my interns, always would treat and teach, would teach my comrades is that you literally have to wash your face after you enter and exit in and out of different rooms, because you cannot show up with that same face, with that same belief system, with those same emotions into your next client's room. And their experience is their lived experience. And so I've been working as a part of my research and in educating medical providers and nurses on chronic pain treatment for marginalized populations for the last 5 years. And it's a continuous battle for them to realize that there's no one tool that's going to substantiate and validate the patient's experience when they're communicating the level of pain. So what are some of the theoretical approaches that work better when it comes to social justice and racial trauma? Because often one of the biggest things I heard, I never forget when I had opened up, our private practice, was a client came in and said, I found you on Psychology Today, and you was Black, and you look like me, and you was dark skinned, so I had to come try you. And I said, okay, well, have you been to counseling before? And she's like, yes, I have, and it was horrible. She said the therapist kept trying to get me to cognitively reprocess and reprogram my experience that I faced in dealing with an officer in the court. I said, well, what do you mean reprocess and once again rewire this thinking? She said they kept trying to use this thing called CBT and telling me to process this differently, to look at it from a different lens. And so we have to be mindful as clinicians, and that not all theoretic approaches are appropriate. And even sometimes within those theories, they can work, but sometimes the particular interventions that we use that are most popular within those theories are not appropriate for racial trauma. Some better fit approaches and theoretic approaches to racial trauma, these are just a few of the ones that I will share. This is not an all-inclusive list. EMDR, EFT, brain spotting, solution focused, experiential therapies, DBT, neuroaffective relational model, NARM, internal family systems, liberation and ethnopolitical psychological approaches, narrative therapy, which is great because many minority populations are narrative people. Let's use it. Bowen Family Systems Theory, Reality Therapy and Choice Therapy, Existential, REBT, ACT, somatic, motivational interviewing, psychodynamic therapies. Again, be as creative and eclectic as possible. Combine theoretic approaches with also holistic approaches. Are you using acupuncture, acupressure, tai chi, yoga, Reiki? Or once again, are you using maybe theater and arts, such as maybe even music therapy or art therapy, or once again somatic sound? And so we have to remember that to address this person's racial trauma, if we understand the core root of what that racial trauma was, and we can break those into, especially when we're looking at it from either an EMDR or EFT lens, we can break down those different components that are contributing variables to that trauma. We can focus on each one. So was it the sound of the siren that scared me and made my heart drop? We can focus on that. Is it more? And it's also when I got slammed against the cement. I can focus on that too. Because if we just focus on the full experience of what that racial trauma was, we don't really truly get to the root of it. The root tells us all of the different variables that the person has in their memory catalog about this racial trauma. So again, not an all-inclusive list, but just some of the ones that I wanted to share with you all.
Dr. Watkins, can you share what AOD screening tools prefer to use with students?
It just depends. So in my community setting, one of the most infamous ones that I always use, depending on the type of service they were trying to get referred to, my go-to one was always the SASE, because the SASE can give me multiple different types of pictures of the client. One of the most popular components of the SASE is that it can also tell you especially the newest version, can tell you if they are lying, or if they're also answering randomly. And so even within the SASE, you can break down the components of the questions and categories and see which ones are related to obsession, compulsion, those types of things. And so even if the person necessarily didn't score positive on the SASE to be deemed having a substance use disorder, I can sometimes dig deeper into the questions that had higher numbers compared to the other ones. So the SASE is my go-to one. It's also one that I brought here at the institution that I'm in, because it also the SASE encompasses both alcohol and all drugs. Instead of sometimes when it comes to alcohol, do I use the audit? Once again, if I'm using cannabis, do I use the cannabis assessment tube? I think it's called Qubit. And so I don't want to have to use multiple ones. However, if I have to, I will, because sometimes that person's drug of choice, I need to have a clear picture on their frequency, use, and severity. So I may use the Qubit, but they tell me that once they're high, they start drinking alcohol. So I may use a specific tool on binge drinking, or once again, I may use the audit or something like that. In my knowledge and work in substance use, there hasn't been a tool that I didn't like and that I couldn't necessarily use with marginalized populations, because I'd never let the questionnaire or assessments rule and completely guide my diagnosis. I always ask follow-up questions. So you're telling me that the very first time that you tried any drug or alcohol was at the age of 12. Who introduced it to you? What was the setup like? What was that experience like? And so I go back and I start from the very introduction, and I want to understand that person's lived experience on what it was like, for example, for some of my clients to be given drugs by a cousin, by older aunt. Once again, somebody had slipped PCP or crack cocaine into their marijuana to make woos, and that's how they became addicted to that. So I understand their experience to understand what truly their substance use disorder looks like, and the multiple components that may once again play a part in rolling it.
Thank you, Dr. Watkins.
Mm-hmm.
And so as we look at the approach to how it impacts, I kind of skipped through and went through looking at it, how it impacts student success and retention. EAB has shared this student success blueprint. This has been out for about two or 3 years now. And one of the things it talks about looking at the high need, the rising need, and the low need. But it's very clear if you type it in, you can find it. And when we send out the PDF version of this PowerPoint, it's already hyperlinked in here. But it looks at looking at your student population with need stratification. And I want to emphasize, it says create differentiated care pathways to match different student needs. I can't emphasize that enough on how we should take the time to create different pathways. And if we finally take different pathways, we can acknowledge the differences by still welcoming our students' diversity. And we know we have things that are shared, that are similar, but we have to find ways to acknowledge the differences and the difference in our approach. It's such a necessity, and if we're going to do this right. Another white paper article that came out by the Steve Fund talked about mental health um, um, for African American BIPOC populations. And so if you type in Steve Fund and mental health, you'll see their whole document. But this is a condensed version of that entire document. This is another good one if you want to look at it, Tatiana. And it breaks down how do you move forward post COVID to address mental health and well-being with students of color. And it talks about building trust through a racial trauma informed leadership model by encouraging and listening to student voices to understand their lives. And Dr. Watkins has talked about from the very beginning, almost 3 hours ago, about the lived experience. And if we finally have a way to center their lived experiences, we can change how we do the work that we do and be nimble enough to shift it. We have our core programming and services that we do, but we often don't have enough time to be nimble to shift how we approach our work because we've done this way forever and always, and this is how we're going to do it. And so it allows us to be nimble by having a trauma-informed leadership approach. We treat student health and well-being and wellness as a priority area for investment and not just counseling. We prioritize funding when we make budgetary decisions, and we provide access to diverse, culturally competent health and wellness practitioners. We engage faculty and staff to support student health and wellness and ensure there is a focus on faculty staff well-being. You can't just pour all into the students, and your employees who are providing these extraordinary services are pouring from empty cups. You got to do both. You want to build alliances and coalitions to have a collaborative approach, mapping out your potential allies. This is going to be key for the clinical components on what your referral process looks like. I had a chance to talk to some students, and they was like, it's so good to be in Columbus and to see how easy it is to refer students out. And they was like, Dr. Elbert, it is like a deer in headlights when we know that we need to go see someone off campus. And I took the time to kind of walk them through how my sister explained to me how finding a therapist can be like finding a good hairstylist or barber. Most of them offer free informational interviews where you get to talk to them, they get to talk to you, see if you all are a good fit for each other. That's the only time fit is appropriate. Not for a job, not for an organization, but fit when it comes to a therapist or a clinician or someone you're going to provide care for you. You also want to invest in partnerships with local faith and cultural organizations. K through 12 is going to be just as important because this is your pipeline into your organization, your campuses. And I want to emphasize, a lot of us who are at public institutions, we shy away from anything faith-based, but we have to make sure we don't shy away from anything spiritual or faith-based because this is what students have potentially leaned on for their healing and for their ability to thrive and be resilient. And so when we take that off as an option when they come to our campuses, we've just cut them off almost at the knees of having a resource. Have a social justice practice in what we do, which emphasizes resources for communities to address the social and economic inequality that affect marginalized and minoritized populations. And so you can't do that when you have volunteer-based programs. And you see in parentheses, paying peer educators. These peer educators are trained to do dynamic education on really tough topics for free. But in comparison, we will pay somebody to work the front desk at the library, at the union, or some other space across campus, but we won't pay these students to be trained to do health and wellness coaching, peer education. It involves motivation interviewing. If we really want these students to be here and do this dynamic work, let's pay them because they also have to represent the diversity of our students. And last but not least, looking at that social ecological model, review our policies to create policies to ensure we have centered health and well-being. And then how do we advocate for cultures of care? We need to make sure as leaders and workers in higher ed We put the needs of our vulnerable populations in the most centered strategic place in how we approach our work here on our campuses. We have to cultivate habits of truth telling and truth hearing. If I can underline that. I don't know if Sheree remembers our teacher from the Career Center for Health Occupations. When she wanted to emphasize something important, she would say hint, hint, highlight. And so this is my hint, hint, highlight moment. We have to cultivate institutional habits of truth telling and truth hearing, critical self reflection, and accountability. We must consciously and intentionally empower those habits on our campuses to meet that calling. This is what it means to have a culture of care. It's not just enough to have a care team. That's not what cultures of care is. And from the perspective of care, in contrast to the perspective of justice, one must attend with the sensitivity to particular others. In actual historical circumstances, one seeks satisfaction relation between oneself and these others. One cultivates trust. One responds to their needs, aiming at and bringing about, as best one can, the well being of the others along with that of oneself, especially when you have a place of privilege. And that includes me because I am in a place of privilege as an AVP. And last but not least, colleges and university leaders should act urgently to protect the health and well-being of your most marginalized and minoritized students, those who are in the margins and on the margins. And you should know who they are when they step foot on your campus. It shouldn't be when they're at the time, when they're at your care teams or whatever other teams that you all have, when they're at crisis. You should know who they are by the time they come to your campuses, even if they are, I hate to say flagged, but kind of flagged of, hey, let's watch out, because they may meet some criteria around not having access to the social determinants of health. And I'll give you an example. So we go to the Nationwide Children's Hospital here to get our munchkins for specialized help and assistance. And every appointment, the nurse comes in, does the basic workup, height, weight, all that good stuff. But they do a screening around the social determinants of health. But they don't. And I was like, wait a minute. And they ask about basically it's a basic needs survey. Do you have running water? Do you have lights? Do you have transportation? Are you on the verge of homelessness? Is there any insecurity, domestic violence, safety concerns? How drastically different if we did that and we implemented into multiple ways of how we engage in health and well-being work for the students that we serve and for the employees we employ. If we actually look at serving them holistically within those determinants of health and things that impact them. And so I'm going to leave you all with some homework. And if we had a chance to do a whole nother hour, we would talk about how you all do the work around healing and well-being for your own self, because self-care starts with you all before you pour it out into others. But for your own care, this is something that you do on your own, but this is your homework. Have you identified your service gaps on campus? And within those service gaps, have you identified the gaps as far as populations you aren't serving? And if you are serving them, are you serving them effectively? Are there funding streams that you haven't thought about that or you haven't assessed? It could be grants, it could be other areas across campus. Is it looking at a new fee, expanding the fee? Are there any places that you're spending money that can be where you can be collaborating and saving money? My favorite thing to ask coming in, is there time? Can you sunset some things? And usually people are like, oh no, we've been doing it. We're doing great things. No, no, no. But can we stop doing some things to be able to have space to do some other things that are innovative in serving our students who actually need something different? Who is holding the department back? So ensuring the health, safety, and wellness of our students is and will continue to be a priority for the university and the institutions of higher education if we choose to do that. Well-being should be central to the students' academic, personal, and professional success. Because don't forget, we bring them here to obtain a degree. but we employ them after this to be good citizens within our communities. And if we do it well, we've given them life skills, we've given them a chance to build up some advocacy on how they can do that outside of the walls of our institutions. Simply stated, in order for students to do well, they must be well. So with that being said, we'll transition and open up any questions that you all may have, and we'll make sure we get the PDF to them so they can provide the PDF for you all and get you all our contact information. So I'll cut off the slide and just put us up on the screen, Dr. Watkins. But I want to open up for any questions that you all have. Can you see the questions too, Dr. Watkins? So Hyam said, thank you both for such a phenomenal presentation. Always humbled and inspired by individuals who have the courage to not only do the work, but to also have these essential discussions to help move the needle towards a more inclusive world where we all can thrive in. Much appreciation to you both. Standing ovation. Thank you so much.
So much.
And just know we're resources to you all. I'll make sure I put up our contact information if there's no other questions or comments. And feel free to give us feedback. This is coming up for us. We'll do this at NASPA Strategies in January. So we're open to any feedback. We won't have this much time, so it's going to be a definitely a much condensed version of this presentation, but we'll be doing a version of this at NASPA Strategies in January in Boston. Here's our contact information. And then we're both also individually on LinkedIn. Feel free to connect with us on LinkedIn. But other than that, I appreciate you all's time, energy, and engagement. We'll make sure we provide the PDF of this to the planners, Madison, and we will sign off. Dr. Watkins, any final thoughts you want to share?
No, just thank you all for your time. Again, 3 hours is a lot, but to come and attend to once again, so we can all become better in serving diverse populations. I'm greatly appreciative to be here, and thank you for allowing us to be here.
Same here. I wish you all well in time and place and space. And again, happy to be resources to you all, and hopeful to see you all in all of the spaces that'll be coming up over the rest of this year, next year, over Zoom and meetings and conferences, so we can engage in doing this work so much more. So thank you all and have a great weekend. Be well.
Thank you.